Hello everyone and welcome to the 32nd International Congress on Pediatrics. In today's webinar agenda, we will be covering cardiology session. We invite physicians around the world to join us and share their experiences with us. This is the fourth day of our online webinar and we're happy we were able to perform it in a timely manner. I hope you haven't missed those 3 days. If so, don't worry because you have access to recorded sessions on our website. Thank you for joining us today. I'm Seville Abdulmohammadian, third-year pediatrics resident here at Children's Medical Center, Pediatrics Center of Excellence, Tehran University of Medical Sciences. And I'd like to introduce you to today's panelists. We are so happy to have with us Dr. Amir Reza Hosseinpour, Department of Cardiology, Surgery, Virgen del Rocio Children's Hospital, University Hospitals of Seville, Spain, on the subject of surgery for univentricular hearts in the neonatal period. We have Professor Sarah Badran with us, attending cardiologist and co-director of Cardiac Catheterization Laboratory in the Heart Institute at Children's Hospital, Los Angeles, on the management of aortic stenosis. Dr. Israel Valverde, MD, consultant pediatric cardiologist, Evelina Children's Hospital, King's College London, UK, and Cardiovascular Pathology Group, Hospital Virgen del Rocio, Seville, Spain, on the subject of virtual reality and 3D models for preoperative planning in congenital heart defects. And Dr. Guiti Milani, Director of Cardiac Laboratory Hospital, if I'm pronouncing it right, Necker-Enfants, maladies, Paris, France, on the subject of Percutaneous closure of patent ductus arteriosus in premature infants. I'd like to take a moment to thank our speakers, our dearest panelists for joining us today. I would also like to take this opportunity to thank Vice Chancellor for Global Strategies and International Affairs, Directorate of International Relations of Tehran University of Medical Sciences for giving me the privilege to patron this important event. I also would like to thank our dearest audience for joining this event, and I gotta tell you, we weren't here if it wasn't for Dr. Ziai and Dr. Aghai. Thank you so much for making all this happen. Dr. Aghai, please.
Thank you, Seville. I would like to thank all of our guests and audiences that are participating in this event. A special thanks to our good friends, Dr. Guiti Milani, Dr. Hosseinpour, and Israel, who is with us right now. And I wish we will have Dr. Badran a little bit later. And thank you very much. Let's go and start the panel.
Thank you. A few reminders before we get started. This webinar is broadcasting live on YouTube. A recorded version of this webinar will be available on our website. Information about our social media is provided on the chat section. Due to the number of participants, make sure to mute your microphone during the lectures. If you have the questions, we encourage you to ask them via chat section, and there's a webinar tool called Raise Hand, so we will be able to hear from you live after each lecture. Please feel free to ask questions at any point during the presentations using the chat section at the bottom right of your screen. We will reserve time at the end of each presentation to answer questions. We will do our best to answer as many questions as possible throughout today's event. If you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. For our Iranian audience, if you want to receive CME credit, don't forget to participate in the panel quiz in maximum of 2 days on cmequiz.ir. Don't forget to follow our social media pages and YouTube channel to stay updated on our next event. And with that, we will open today's webinar. We are lucky to have with us today Dr. Amir Reza Hosseinpour. Dr. Hosseinpour, we're all ears.
Hello everybody. Thanks very much. I was under the impression that you were going to use the recording of my presentation. Is that not correct?
Yes, of course. I can play it for you.
Amir, it is okay. We can just play it right now. It's completely up to you.
Yeah, okay. Do that because internet might break down because there's works going on in my building and electricity is
okay. So you just stay with us for the Q&A after. Thank you very much. Thank you.
Okay. All right.
Thank you. Let's go. I will play the pre-recorded version right now.
Hello, everybody. Thank you very much for giving me the honor of participating in this Congress. I'm going to talk to you about surgery for univentricular hearts in the neonatal period. So let's get that.
Sorry, we will play it again, and I think the inconvenience will be over.
Surgery for univentricular hearts in the neonatal period. So let's get down to it. Let's start by defining what a univentricular heart is to begin with. A univentricular heart is not a single malformation. In fact, it is an imprecise and misleading term because it implies that the heart in question has only one ventricle, which is generally incorrect. In fact, a univentricular heart it's really a spectrum of malformations in which the ventricular mass may not readily lend itself to partitioning that commits one ventricle to the systemic and another to the pulmonary circulation. This could be because of lack of feasibility from an anatomical point of view or advisability of partitioning. In other words, a univentricular heart is a heart with a malformation that cannot be corrected for whatever anatomical reason. For example, it could be that one ventricle is not sufficiently developed, or it could be that there is a very large VSD such that there isn't enough septal muscle available for a proper correction. Or it could be that there is straddling of the mitral valve across a large VSD. Or it could be that one of the ventricles is not readily connectable to an adequate outflow tract. All of these are examples of a so-called univentricular heart. This assessment is sometimes difficult. Some hearts don't easily fall into this category, and some of them may be considered to be borderline. So let's say that you have made the diagnosis of univentricular heart by whatever means. The question that arises is, how do you treat univentricular heart? Well, we've already ruled out anatomic correction such that such hearts can only be palliated. What does that mean, palliation? It means making the heart as functional as possible, although a normal circulation cannot be achieved. A normal circulation can only be achieved with heart transplantation, which has its own problems and is best delayed as much as possible, if possible. This is really what palliation does. It delays transplantation as much as possible by reducing patients' symptoms to acceptable levels. So, the objective of the treatment of univentricular hearts is to make a dysfunctional heart as functional as possible. How does one do that? How can we make a dysfunctional heart functional? Well, this may be done in different manners in different age groups, but all strategies at all age groups have three principles in common, independently of which strategy is used. The first one is that the entire ventricular mass is considered to be a single ventricle independently of its intracardiac morphology. Hence the term univentricular. This is why they're called univentricular hearts. They are functionally univentricular, not necessarily anatomically. This is the first principle. So the second principle is that this single ventricle must support both circulations, pulmonary and systemic. But the systemic circulation must be treated first, must be given priority. In other words, the ventricular mass must eject blood into the aorta without any obstruction. This is the second principle. The third principle is that having made sure that the heart as a whole functions as a single pump, and that it ejects blood into the aorta without any obstruction, then and only then some measure is taken to establish pulmonary blood flow by diverting blood from the systemic circulation towards the lungs. This is a fundamental doctrine in cardiac surgery. It comes up a lot, even in corrective surgery, not just palliative surgery. And that doctrine is this: first, give the available good material to the systemic circulation until all its requirements are met, then give the rest of the tissue available to the pulmonary circulation, supplementing it if needed with other material. It comes up all the time, this doctrine. The systemic circulation has priority. This is a key issue. So, what are the differences between the different strategies in different age groups? We've already mentioned what they have in common, the three big principles they have in common. What are the differences? Well, these different strategies in different age groups differ only with respect to the source of pulmonary blood flow and the pathophysiology of each source. That's all. There's nothing else that's different between them. So let's see. In patients who are older than 4 or 5 months old of age, pulmonary blood flow may be established by diverting blood from either the ventricular mass itself, the so-called single ventricle, or from a major systemic artery, which may be the aorta or maybe the subclavian artery, for example, or the vena cava. It could be either the superior vena cava or both vena cava, assuming there is no pulmonary hypertension. However, in neonates, the vena cava are not viable options for this because their pressure is too low to drive blood through neonatal lungs, because pulmonary vascular resistance is still quite high in the first few months of life. So pulmonary blood flow must come from the ventricular mass itself or from a systemic artery in the neonatal period. This, on the other hand, has the opposite problem in the sense that it comes from systemic pressure. You need systemic pressure to drive blood through lungs with relatively high pulmonary vascular resistance. But the pressure is so high that these may generate too much flow and pressure. So, in practice, in neonates, pulmonary blood flow is established from a systemic arterial or ventricular source, but this is deliberately restricted using a small shunt or pulmonary artery banding as needed, thus limiting flow and pressure to adequate levels. So, having done this, having followed these principles, what physiology do we impose on these babies? What pathophysiology, what is going to be taking place in these babies with this kind of approach? Well, what we do establishes a pulmonary circulation that is in parallel with the systemic circulation. It is an offshoot of the systemic circulation and takes place simultaneously. Blood is diverted from the systemic circulation to the lungs, and after gas exchange is returned to the heart, where it mixes with the systemic venous return. This mixed blood in the heart will have an oxygen saturation of about 80% in stable and well-balanced circumstances, and is then ejected into both circulations, systemic and pulmonary again, simultaneously. This is a state of both hypoxemia and volume overload. Hypoxemia because of mixing of the pulmonary and systemic venous returns within the heart or around the heart, and volume overload because the...
Sorry for the inconvenience. I think I'm going to replay it. There was a technical problem. I'm so sorry. I will fix it.
is going to be taking place in these babies with this kind of approach? Well, what we do establishes a pulmonary circulation that is in parallel with the systemic circulation. It is an offshoot of the systemic circulation and takes place simultaneously. Blood is diverted from the systemic circulation to the lungs, and after gas exchange is returned to the heart, where it mixes with the systemic venous return. This mixed blood in the heart will have an oxygen saturation of about 80% in stable and well-balanced circumstances, and is then ejected into both circulations, systemic and pulmonary again, simultaneously. This is a state of both hypoxemia and volume overload. Hypoxemia because of mixing of the pulmonary and systemic venous returns within the heart or around the heart, and volume overload because the single ventricle, supposedly single ventricle, so-called single ventricle, has to provide both circulations simultaneously. This mode of function is called univentricular physiology, which is a term that refers to a circulation in which two conditions exist. The first condition is that there is complete mixing of the pulmonary and systemic venous returns somewhere in or around the heart. That's the first principle. Second, that this mixed blood is ejected simultaneously, in other words, in parallel form, to both pulmonary and systemic circulations. In other words, pulmonary blood flow comes from a systemic arterial or ventricular source. This is so-called univentricular physiology. So it's important to note that the term univentricular physiology is sometimes applied erroneously, by mistake, to other palliated states where pulmonary blood flow is established from the veni cavi, in other words, from Glenn or Fontan operations. It's important to realize this is incorrect. Those palliated states have their own physiologies, Glenn physiology and Fontan physiology, but not univentricular physiology. Neither of the two conditions written in blue here exists when pulmonary blood flow comes from systemic veins. It's important to know this because many people use the term univentricular physiology, for example, in a Fontan. Fontan is Fontan physiology, it's not univentricular physiology. It's just something to keep in mind. So, one can say, therefore, that the pathophysiological objective of surgery for univentricular hearts in neonates is to establish an unobstructed and well-balanced univentricular physiology. Of course, this is nothing new to the baby. The fetal circulation is also in such parallel mode, although not with respect to the lungs. It's in parallel mode with respect to the placenta, but it's still a parallel mode. Likewise, the postnatal preoperative circulation established by a univentricular heart and an open arterial duct is also in parallel mode. That's also univentricular physiology. So it's nothing new. It's nothing new to the baby. However, surgery may still be needed to make this stable and well-balanced. How do we do that? We do that by eliminating all obstructions and increasing or decreasing pulmonary blood flow as necessary. A well-balanced circulation means that pulmonary blood flow is equal to systemic flow. In other words, a QPQS of about 1, which results in a systemic oxygen saturation of about 80%. So these are the principles. How do we actually do it? What surgical technique is used? Well, we've already seen that the anatomy is very variable. Of anatomy of a univentricular heart. Therefore, it's not surprising that the surgery needed for treating it, or the interventional technique, whatever technique is used, is also variable. So, neonatal cardiac surgery for univentricular hearts is not one specific operation, but it is a specifically formulated operation composed of various possible components such that the overall procedure is tailor-made to each patient. Formulating the operation is conceptually simple, even if technically demanding. But you formulate it, you form a recipe, if you like, by asking the following questions and acting according to the answers. What are those questions? Let's have a look. The first question is there unobstructed passage of blood between the right and left sides of the heart? This is very important. If the heart is to function as a single pump, then there must be free passage of blood between the two sides. In other words, there must be either an unrestricted atrial septal defect, ASD, or an unrestricted ventricular septal defect, VSD. If there isn't, the patient needs an atrial septectomy or septostomy. So that's already one component of the operation that you know you have to perform. Whatever the final operation will be, it must include a septostomy or a septectomy. So that's already part of the ingredients. Next question, are both venous returns unobstructed? All obstructions must be corrected. If there is cor triatriatum, for example, it must be corrected. Obstructed pulmonary venous drainage must be corrected. There must not be any obstruction. So that's the second component that may or may not be needed in the operation. Are there at least one adequate atrioventricular valve and one adequate ventricular arterial valves? One of each type of valve is sufficient because the heart functions as a single ventricle. Therefore, only one atrioventricular valve and only one ventricular arterial valve is needed. So valve repair may or may not be needed. If there are two valves of each type and one of them is dysfunctional, it may be excluded. You can close it as long as the other valve is okay. You only need one valve of each type. And that may or may not have to be added to your overall operation depending on each heart. Next question, is the systemic circulation unobstructed? All systemic obstructions must be corrected, such as subaortic stenosis, hypoplastic aortic arch, coarctation, whatever. There must not be any obstruction, not in the systemic circulation or the venous circulation. There must simply be no obstruction in a univentricular heart, in a circuit established by univentricular hearts. Next question, are left-sided structures underdeveloped, such as, for example, a underdeveloped left ventricle or mitral valve or aortic valve? If so, the right ventricle must support the systemic circulation. How do we do that? We do that by transecting the main pulmonary artery and anastomosing it to the ascending aorta or aortic arch. Alternatively, the pulmonary artery may be connected to the aorta by stenting the arterial duct. This again goes back to the doctrine that we've already mentioned. That is, all the good material available must first be given to the systemic circulation, and then we worry about the pulmonary circulation. If you have only one ventricle that's functional and it happens to be the right ventricle, well, you have to give it to the systemic circulation. Systemic circulation always has priority. Next question, does pulmonary blood flow need adjusting? If it's too low, it may cause too much cyanosis. You have to increase it with a shunt or with percutaneous pulmonary valvuloplasty or stenting the arterial duct, depending on the exact anatomy of each heart. If it's too high, it will cause too much volume overload and heart failure, and it must be reduced by pulmonary artery banding or bilateral banding. If in the case where you've connected the pulmonary artery to the aorta by stenting the arterial duct, well, there will also be too much flow in the branch pulmonary artery, so you have to do lateral banding in that situation. If pulmonary blood flow is well balanced, well, leave it alone. So these are the questions that must be answered, and the answers tell you what operation you need. The exact required intervention depends on which repair components are required. So at one extreme, the circulation may be naturally in a stable and well-balanced mode, such that no intervention is needed in the neonatal period because of that particular heart. At the other extreme, most of the repair components may be needed and would have to be combined in a single complex operation. This is really the Norwood operation that I'm talking about. Between these two extremes, some neonates need less complex interventions. And if only simple measures are needed, these may be done by catheter techniques percutaneously, for example, a balloon septostomy or stenting the arterial duct or the pulmonary artery. Likewise, complex surgery may be replaced with a combination of surgical and catheter-based techniques, so-called hybrid approach. This depends on the expertise available in each center. Now, a word about the approach. How do you get to the heart? Sternotomy or thoracotomy? This is worth talking about in the context of univentricular hearts. These operations for univentricular hearts are done generally through a median sternotomy. Even if the only procedure needed is a shunt or a pulmonary artery banding, sternotomy is still better and is wiser. The reason is there are four reasons for this. First, both sternotomy and thoracotomy cause formation of adhesions, which are initially quite vascular. After thoracotomy, however, in hypoxemic patients, part of that vascularity will develop into systemic to pulmonary arterial collaterals, which may create problems later on. This may be avoided by correcting the hypoxemic condition during the same act or soon after, but this is not possible in neonates with a univentricular heart. Therefore, a sternotomy would be better in order to avoid all these collaterals. Next reason, the second reason, is that a thoracotomy may be fairly benign in adults who do not grow anymore. But in babies who still have to grow to adult size, a thoracotomy may alter growth patterns with a risk of scoliosis. The third reason is that these babies are generally quite unstable. Now, a sternotomy allows easy use of cardiopulmonary bypass if the baby becomes too unstable. The fourth reason is that these babies are likely to need further palliative procedures in the future through a sternotomy. Therefore, doing the shunting or banding procedure also through a sternotomy avoids giving these patients, an additional scar. So, having talked about the operation, it's also worth talking about the preoperative management because it's very important in such potentially unstable babies. Results of surgery are best, obviously, if patients are maintained stable preoperatively. How do we do that? Well, there are essentially three major components in the preoperative management. The first component is that in babies with inadequate outflow to either the systemic or the pulmonary circulations, the arterial duct is maintained open with a prostaglandin infusion. This allows blood flow from one circulation to support the other in parallel mode. This is one major component. The second major component is avoiding both overventilation and a high FiO2, since these reduce the arterial CO2 and increase the arterial oxygen respectively. And both of these features cause pulmonary vasodilatation, thus reducing pulmonary vascular resistance and increasing pulmonary blood flow with consequent worsening volume overload and in fact creating cardiac dysfunction. So mechanical ventilation is in fact best avoided preoperatively, and these babies should be breathing room air. Now in babies, that's the third major component. In babies who need an atrial septectomy or septostomy, don't wait for the operation to do that. You can do that at the bedside with a balloon technique, and this may help stabilize the baby prior to surgery. These are the three components of preoperative management. Now, these patients are clinically challenging because their physiology is innately unstable by being both hypoxemic and volume overloaded, as we've discussed already. Now, they have saturations of 80%. Is this harmful to these babies? Well, No, it's not, because don't forget, these babies have just spent 9 months with saturations of less than 70% in the upper body and less than 60% in the lower body. So a saturation of 80% for them is luxury, as long as saturations don't go above that for more than a few days before surgery. That is important. If preoperative saturations increase to high levels due to increase in pulmonary blood flow as pulmonary vascular resistance drops, and saturations stay high at least 5, 6, or 7 days, the baby will not tolerate low saturations again due to chemoreceptor resetting. After this point, lower saturations will make the patient ill by chemoreceptor stimulation. Chemoreceptors were adapted to low saturations in utero, but after birth, when saturations go up, the chemoreceptors reset, recalibrate, and this is irreversible. And low saturations cause problems by making patients breathe faster and more deeply, which is hard work, and also stimulate the sympathetic nervous system with much increased levels of catecholamines, and they all cause symptoms. This is a problem, especially if there is an unrestricted source of pulmonary blood flow in these babies, such as a non-stenotic pulmonary valve and artery or a large arterial duct, or if pulmonary blood flow increases significantly as pulmonary vascular resistance decreases and saturations increase. These increase the risk of surgery significantly, not only because of chemoreceptor resetting, but also because volume overload becomes more severe and the baby will be in worse conditions at the time of surgery. How to avoid this is to not allow oxygen saturation to increase much above 80%, which is before surgery, which is what happens after surgery. So they must not go above that before. So that they don't reset their chemoreceptors. Best way to achieve this is to operate early, within the first 5 days of life, before pulmonary vascular resistance has the chance to come down. This also means if you operate early that chemoreceptors are not given time to reset, even if saturations do go up. Of course, if pulmonary blood flow is naturally restricted, preoperative saturations remain low and the issues of chemoreceptor resetting or volume overload do not arise. In other words, later surgery would still be safe. Lastly, I would like to make a comment about the use of extracorporeal membrane oxygenator, ECMO, in babies after surgery for univentricular heart. Chemoreceptor resetting is a problem in this setting because it makes the use of ECMO problematic, because ECMO establishes saturations of 100%. Every time you put a patient on ECMO, the saturation becomes 100%. Now, if support with ECMO lasts 5 days or more, 5, 6, 7 days, and the chemoreceptors reset and the baby cannot go back to a saturation of 80%. In other words, you cannot wean the patient off ECMO. This is a big problem. In addition, if a shunt is present, this may become blocked by thrombosis despite adequate anticoagulation. This is because shunts from systemic arteries must be clamped while on ECMO. Otherwise, much of the output of the ECMO is diverted to the pulmonary circulation. If a shunt is from the ventricle, if it arises from the ventricle, it does not need to be clamped, but will naturally have a very low flow on ECMO, which also leads to thrombosis. So in fact, ECMO, not surprisingly, has been consistently found to be least successful after univentricular palliation. So that's all I have to say, and I would like to thank you all very much for your attention. Thank you.
Thank you, Professor Hosseinpour, for your great presentation. I believe we have some questions in the chat section. If you're ready, I would ask you.
I'm ready.
Okay, we have a question. What is the age that is the cutoff for stage 1 palliation or PA banding in your opinion?
in babies who have a tendency to increase their saturations as pulmonary vascular resistance drops, you would be in a hurry to operate on these babies. You do not want to give time to the chemoreceptors to reset to high levels. So the minute you see, the day you see that oxygen saturations are increasing to 90% or more, then problem is starting. You need to operate quickly, partly to avoid resetting of chemoreceptors, and also, let's not forget, as saturations increase, that means pulmonary blood flow is increasing, so you are increasing heart failure. That means that the baby will enter your operating room in a worse condition. Now, if we're talking about univentricular operation in a neonate, we are talking about high-risk surgery, even in the best cases. Even if they come in excellent conditions to the operating room, you have a challenge in front of you. So if they come already in a bad condition, well, that's even worse. So as saturations go up, you should be worried. Now, sometimes some babies have malformations that do not allow saturations to go up. Let's say they have a natural pulmonary vulva, pulmonary outflow stenosis that is severe, and their problem is more hypoxia than heart failure, and their saturations remain low. In those babies, there is no rush. You can take your time, you can operate whenever you like. For example, if what they need is a shunt, well, it doesn't matter. You don't have to run and do it in the first few days of life. You could, I've done that at 3 weeks of age, no problem. But those are the cyanotic ones. So it all depends on keeping an eye on saturations and pulmonary blood flow. If those start to go up, you want to operate on those kids before 1 week of age.
Dear Dr. Hosseinpour, in my opinion, the $1 million question is that what is the end of this cutoff? For example, if you have a child with the age of about 7 months is come to you with the pulmonary hypertension and single ventricular physiology, do you still recommend to go toward the Fontan operation for him or her?
Well, that depends entirely on your pulmonary vascular resistance. If you would need to catheterize such a baby. You need to measure pulmonary arterial pressures and resistances. Now, if those happen to be low, which they may well be, because if they had naturally restricted pulmonary blood flow, that may have protected the lungs, and your resistances and pressures allow proceeding to a superior cavopulmonary anastomosis and later proceeding to Fontan. If, however, you do your catheterization and you see that you've missed the boat, you see that pressures are too high, resistances are too high, and you don't dare do a cavopulmonary anastomosis, one option would be to, those are the babies that had unrestricted pulmonary blood flow to begin with. Otherwise, they would not have an increased pulmonary vascular resistance. In those babies, you may consider doing a pulmonary arterial banding to protect the lungs and treat them with a pulmonary vasodilator for a few months and recath them to see if you can reduce the pressures and resistances low enough to proceed with cavopulmonary anastomosis. If you do, great. If you don't, then maybe that banding is the end of the line of palliation. They'll have to live with pulmonary arterial banding forever. In Seville, in our adult congenital unit, we do have something like a handful, 7 or 8 or maybe 9 adults who are in their 50s, who were detected late as a child I mean, we're talking 50 years ago, so they did not have good facilities. They were detected late, they were banded, and resistances didn't come down, and they've been living with their band ever since. And they have saturations in the mid-80s, let's say 83, 84%. They are cyanosed, they are limited in their efforts, but they are alive. That's the key point. How many Fontans do you know who are alive at the age of 55 and who are actually living? Forget about being limited, actually alive. So one wonders about the philosophy of all of this. What are we doing? Is it worth it? Overall, it is felt that going towards a Fontan is better, beg your pardon, because of normalizing saturations. That's what the benefit of Fontan is. It gives you a good saturation. But everything else about Fontan is a disadvantage. Fontan is a saturation augmenting operation. That's all. But in order to buy that, you have to spend a lot. Everything else is a disadvantage. Now, we have these adults who are in their 50s. I think we have 7 or 8 or maybe 9 of them, who are in pretty good shape. If you don't ask them to do heavy sports, I mean, they do gentle sports, they walk, they may play golf, they can't run really, but they're alive in their mid-50s. You know, I'd like to see how many Fontans people have who are like that. So, but at the end of the day, it all depends on resistances and pressures.
Thank you very much. Thank you very much. There are too many questions. Just if you can just answer them very quickly on the chat section, because we should go on because of the time. If you can just answer them on the chat section, that would be great.
I can do that directly on my computer here.
Yeah, you can just while the other presentation is going on, you can just answer them in the chat section.
Okay, I'll do that.
Thank you very much. Thank you, Reza. Thank you
pleasure.
very much.
Thank you.
Okay.
Thank you.
Let's go.
Thank you, Professor Hosseinpour. I believe we needed to go to Professor Guiti Milani, but here I have a technical problem for pre-recorded sessions, so I'm asking to go to Professor Israel Valverde, and we do not have it. Okay, Professor Milani, are you with us?
Hello? I'm here if you want.
Yes, of course. First, let me ask a little question from Dr. Guiti Milani.
Can you hear me?
Yes, I can. I'm sorry. I really am sorry, because somebody told me that Dr. Milani is having a kind of situation that she has to run the catheterization lab. So if you may, Professor Valverde, I will ask Professor Milani first to present, and then we will have you, if it is okay.
Yes, sure.
Thank you. Thank you very much.
Thank you, really sorry. Professor Milani, we are all with you.
Okay, let me share my screen.
We have your screen.
Okay. So I would like to thank you all for the very kind invitation. It's a pleasure for me to talk to you about percutaneous closure of PDA in premature infants. We just have one disclosure, which is that Abbott has given us a grant to run our registry. And I would like to dedicate this talk to my father, Dr. Hossein Milani. If we go through history of the PDA, the first description of a PDA is quite old and is found in the literature in 1882, and it's a medical description of an aneurysm secondary to a PDA. If we look about surgical technique regarding to PDA, we have to wait for a few decades, and the first surgery was described in 1939 by Gross, and he described a thoracotomy to close the PDA. And you have to wait 30 more years for the first intervention described by Portsman in large infants. And it's just only in 2013 that we have the first description of transcatheter PDA closure in premature infants. If we talk about neonatal care, if you have full-term infants, more probably the duct will close spontaneously within the first hours or the first few days after life. But the more premature you are and the more low birth weight you're born with, the more likely the PDA will not close and or will have a significantly delayed closure. And approximately 20% of the very premature and very low birth weight infants will have a PDA, a significantly PDA with left to right shunt causing symptoms. There are four ways to treat the PDA. One of them is just observation, and some teams just believe that having a PDA in a premature infant is just the normal history of prematurity, and they just let the PDA go to its normal, to its natural evolution. Some of the teams will go for medical care and will give paracetamol or ibuprofen to the kids to have closure. Some team will go for surgical ligation, and some teams will go for transcatheter PDA closure, which is what we're going to talk about today. As you all know, having a very large duct will have clinical findings. You will have pulmonary congestion with pulmonary overflow. You will have systemic hypoperfusion, and this will have repercussion on three main organs. One of them is the gut with necrotizing enterocolitis. You can have renal insufficiency and cerebral hemorrhage. What is a significantly hemodynamically significant duct? I have said echographic finding and not echocardiographic findings because I think you have signs of hemodynamically significant duct in the heart, but also outside the heart. The PDA is usually larger than 1.5 millimeter or 1.5 millimeter per kilo. You will have left heart volume overload with a left atrium to aortic ratio above 1.5 of a very enlarged left heart. You can have a very large pulmonary venous return. Neonatologists like to look at the mean flow velocity in the left pulmonary artery, which is usually above 0.35 meters per second. And also they like to look at the end diastolic flow velocity in the left pulmonary artery. And they also really pay attention to the null or reversal diastolic flow in the abdominal aorta, the mesenteric artery, and the cerebral artery, which are the signs of hypoperfusion in those organs. Are there contraindications in percutaneous closure of the PDA? I would say that if you look at cardiovascular contraindication, aortic coarctation, or very small left pulmonary artery, or intracardiac abnormalities are contraindication. But hemodynamic instability can usually be managed in the cath lab, and pulmonary hypertension can also be managed in the cath lab. If the baby has transportation that is a bit stormy and come to the cath lab with pulmonary hypertension with a right to left shunt through the duct, if you start to put nitric oxide and you see that there's purely left to right shunt, you can close the duct. Other contraindications are sepsis, that is for sure. Severe brain damage or overall poor prognosis must be discussed, and I think these are contraindications. Severe respiratory instability can be tricky in the cath lab. This is for sure. Uncontrolled enteropathy is usually a contraindication because it is usually it goes usually with sepsis. Hematology like anemia or thrombocytopenia are not contraindication. We transfuse blood or platelets before the procedure, and renal failure is not a contraindication and is more, I would say, an indication to close the duct, and you can do that without contrast injection, so you won't harm the kidneys. If you look at intervention, there has been smooth way between the 70s and where we are now, and it's a smooth transition between the larger kids and the very tiny premature we are taking care now. And this modification, where we were able to go through the modification of the technique with several things. One of them is that the device have a much lower profile now. And the first device where we were only able to use the artery and a very large sheet in the artery. This was in the mid-70s. Then in the late 90s, the ADO device was made accessible, and this made the procedure easily accessible to toddlers. And because of new device, but also because of the modification of the technique that I'm going to go talk to you in a minute, we are now able to treat very small babies up to 700 grams. These interventions have been made possible by several people, and I've put the picture of Dr. Neil Wilson because he was the first one he's a cardiologist who saw that bringing a very tiny baby to the cath lab and closing his duct would be possible, and that it would be no harm, and it would even make him feel better. And he was right. So he was the first one who dared to do that, and then several other doctors really made the technique, brought improvement to the technique and made it easy for everyone to do the technique now. I cannot emphasize enough on this. Bringing a premature baby in the cath lab is a teamwork, and the interventionalist is just at the end of the story. You need a neonatologist to be convinced that he can refer you and bring the baby to the cath lab, and that you will do good to the baby. And as long as the neonatologist is not convinced by the technique, there is no way you can do this technique and develop this technique in your unit. You need a cardiologist who's going to do the echo, an anesthetist who's ready to bring a very small and fragile child out of NICU and bring him to the cath lab. You need a dedicated cath lab team who's used to take care of these very small babies. Obviously, the surgeon needs to be aware of your program and needs to agree with your program. Sometimes you can have trouble, and sometimes you need to have a surgeon backup. It's a challenging procedure. Here is a picture of the baby brought to the cath lab. Transportation is an issue. They're usually transported by the neonatologist team who's in charge of the baby. They're intubated in NICU because the shortest time they're in the cath lab, the best it is for them. They come to the cath lab with their own ventilator. Because neonatologists are used to specific ventilator with high frequency oscillation ventilation mode, and we don't have those in the cath lab. Access can be tricky, and one of the things that you must pay attention to is the temperature. They cannot get cold, otherwise they get very unstable. So if you compare the procedure above and below 2 kilo, if the duct has to be closed in a baby less than 2 kilo, there is a few things that have been modified in the procedure. There is no arterial access. If the artery of a 1 kilo baby is punctured, you will have limb ischemia. Venous access are usually using ultrasound guidance. We don't usually use a systemic anticoagulation. We just use heparin in the fluid that is used to flush the probes. Sorry, contrast and intravenous contrast and radiation must be decreased to their maximal, and we have no proof that you can close a PDA without any contrast injection. Avoid any additional procedures. There no need to measure PA pressure or to quantify the shunt. There is a duct. It has been judged by others that it is significant. You just go there, you close the duct, and you just put the baby back into NICU. The device must sit intraductally, and there is no disc outside the duct. Otherwise, there is going to be left pulmonary artery or aortic coarctation. As I'm going to show you, the temperature probe, the esophageal temperature probe, and the trachea landmark are a good landmark when you deliver the device, and real-time transthoracic echocardiographic guidance is the key to the procedure, and it has to be done by a trained echocardiographist who knows you, who knows what he's looking for, and who accepts to be under pressure when the baby's unwell and when you have a device that you want to know whether you can release or not. These are the images we like to see before the procedure. On the left side of the screen, you see the length of the PDA, and on the right side of the screen, you see the diameter of the PDA, and basically you choose your device before you go to the cath lab. Here is the view of the PDA. You see this very long, very tubular, purely left to right duct, and you see that it's basically the size of the aorta. These are the device that we use, the Emplatz Piccolo occluder. They have now CE marked and FDA approval, and they come in three size, and the size is the waist diameter, 3 millimeter, 4 and 5 millimeter, and they come in three lengths, 2 millimeter, 4 and 6 millimeter. Basically, in premature infants, you want the device to be the shortest, and so mainly we use the smallest length, which is 2 millimeter, and as a rule of thumb, we would add 1 millimeter to the smallest portion of the PDA to choose the device. So if the PDA is a long tubular shape of 3 millimeter diameter, we would use a 5 millimeter waist diameter device. There are two imaging modalities. As I said, you have angiography, and when you do an angiography, you do a hand injection performed from the aortic isthmus to delineate the PDA in lateral projection. It provides morphology and accurate measurement of the duct, but it may underestimate the diameter if there has been a spasm when we have crossed the PDA. And usually 1 milliliter of contrast is enough to have a nice view like you have on the screen. Here is the view of the angio, and you can see the PDA, and here is again the same echographic views that I've showed you. As I said, transthoracic echography and echographic guidance is the key to this procedure. It gives you accurate measurement of the PDA diameter. It may underestimate the length, and during the release of the device, echocardiography is going to tell you whether you have a protrusion into the aorta or into the left pulmonary, and if there is residual shunt. It will also provide valvular and ventricular function if needed. One of the challenges of the procedure is to avoid tricuspid valve damage. There are three approaches that may be used to cross the tricuspid valve and later to cross the PDA without damaging the tricuspid valve. One of them is to use a 4 French glide catheter, and then you would use a floppy 0.035 guide wire, but these are very large and rather stiff guide wire in small babies. The other option is to use a 4 French balloon and hole catheter, so you will not be caught in tricuspid valve chordae and avoid tricuspid regurgitation. And the last technique is the one that I'm using, is the use of a microcatheter to cross the tricuspid valve. And these are angios that I will show you right now. So here is a lateral view of the fluoroscopy of a tiny baby. You have, I don't know if you can see my marker here. Here is the temperature probe, and here is the trachea. You can see the trachea here. Here is the right French, the four French right coronary catheter that is sitting into the right atrium, and the microcatheter has already crossed the tricuspid valve. And here it is crossing the tricuspid valve, and then we put a coronary guide wire here to cross the PDA. Then we advance the microcatheter on this guide wire to cross the PDA. Here, there is again the same lateral view. There is the guide wire and the microcatheter sitting into the descending aorta. And we are going to see the advance of the torque view delivery catheter into the descending aorta. Here, you can see that the torque view catheter is advancing nicely on the microcatheter. And here is the release of the device. You can see that it's sitting anteriorly to the temperature probe, and here is the trachea landmark. And I'm not lying, it's just echocardiographic guidance. As you can see that the echo probe is here, and you see now that the device is released that it sits exactly on the trachea. When we do the procedure, this is the image we love to see. You see the aorta here. I'm sorry, it's not running. You see the aorta, you see the left pulmonary artery, and you see the device just in the middle. There is no residual shunt, no aortic coarctation, left pulmonary artery is patent. We are happy with that. Here is another view. You see the aorta, a bit better. Maybe you see that there is no coarctation and that the aorta is widely patent. And here, on the same baby, you see that the left pulmonary artery is widely patent. Sometimes the babies are very unwell. It can be tricky, but if you take time to get good echo views, you can have nice picture like this. Here you see the device and you see the LPA very nicely. And here you see the aorta. On this view, I would like to insist on this view. If you're not used to this view, you can see, but my God, the device sits into the aorta. And one have to keep in mind that the duct is parallel to the aorta. So there is a projection of the duct just on the aorta. But as long as you see that there is normal flow into the aorta, there is no problem. And it's let's say a fake image. There are 3 different studies. I'm just going to go very quickly through to tell you where we are right now. So here is a multicentric study that we have published a bit earlier this year with 4 centers doing these very small babies. We had 100 patients, mainly the patients were between 1 and 2 kilos with a mean procedure weight in that main subgroup of 1,300 grams at the procedure. But we also had 20 patients below 1 kilo. As you can see, the 4 centers did the same thing, which is PDA closure in premature babies, but we all had different techniques. One of the centers would use fluoroscopy and angiography. The other center just relied on echo and fluoroscopy. All of us used ADO2AS, which is the old name for Piccolo device. And we all use different type of guide wire or catheter, but this is not the main purpose of the presentation here. If you see the PDA dimension, you see that the older you tend to be, the more conical shape the PDA will be, and the very small babies will have a very tubular duct. The other thing that you see on this screen is that if you're happy to close a PDA in a 2 kilo, it won't take you much more time to close it in a smaller baby. You just need to know what is the procedure, and you need to get used to the procedure. So obviously I would not advise to start with a 900 gram baby, but once you know how to do the procedure, there is no real complexity in doing tiny babies. We have a mixed, I have described you all the devices that were used, some MVPs, but mainly ADO2AS, and we will go to complication and death after the procedure. Here is just to show that with experience, radiation exposure was decreased. And with experience, we tended to do smaller babies with larger PDA, and you get to do that once you get more experience. We had 2 left pulmonary occlusion treated by surgery, 1 left pulmonary artery stenosis treated by dilatation, 1 very late aortic coarctation treated by surgery, 3 mild tricuspid regurgitation without no treatment, and 1 aortic arch acceleration just followed up, and now that it has completely resolved with the growth of the child. We did have deaths. And they are all related to prematurity. 2 babies went on to the cath lab with anuria and severe renal insufficiency, but did not recover. So they died of renal insufficiency. 1 of the patients died from cerebral hemorrhage. 1 patient was unable to be weaned from ventilation after 7 months and ultimately died, and 2 patients died of prematurity complications. Here is another study that was published by the Americans, and it's the study they did to have the FDA approval of the Piccolo device. I think this is very important. If the child is less than 2 kilos, the device needs to sit intraductally. And if the child is above 2 kilos, you have less risk of embolization if the 2 discs are sitting outside the duct and the duct is just filled by the waste of the device. In their study, they had 200 patients, 100 patients below 2 kilos and 100 patients above 2 kilos. Roughly, they had the same dimension of our PDA, and mainly these babies were mainly stuck on NICU because of a large PDA. Here you can see that fluoroscopy time was similar to the multicenter study in France, with around 7 to 8 minutes, and they all gave contrast injection. Here also is something that we have seen in our study, but is very well described in their study, is that if the baby is very small, the duct will remain fetal type, which is a very long, hockey stick but tubular duct. And as the baby is getting older and larger, the PDA will tend to be more conical. So in their study, they had very high rate of implant success, and in small children, they tended to use very short device as we do, and in larger children, they used larger and longer device. As you see, they had a very low rate of embolization, and I think all of us will have had that, and it was just because it was the earlier experience, and now that we are more used to the procedure, we don't have so many of these complications. Here is the adverse event. They had no deaths. They did have 1 aortic obstruction, and they also had tricuspid regurgitation. As I said, this is a new technique, and we have growing experience. Some teams have recently shown, because as you see on the bottom of the screen, all these publications are quite new. They have recently shown that you can see ventilation really improves after transcatheter percutaneous closure of the PDA, and it improves much faster when you compare it to surgery. There is no post-ligation cardiac syndrome after transcatheter PDA closure, and I don't know neonatologists in the room, but neonatologists tended to be very stressed when we started the procedure, because they all had in mind the very stormy 24 hours they had all lived with post-operative babies with surgical closure of the PDA. They go to low cardiac output, they have poor function, they need to get diuretics to maintain urine output, and they need to have inotropic support to maintain their blood pressure. And we don't see that complication in after transcatheter PDA closure. We don't really know exactly why. Is it because they have less fluid in perfusion because we don't open the thorax? Is it because the closure of the PDA is less rapid? You don't put a clip on the PDA. You first go in with your catheter, then you put your device in, and the device doesn't thrombose right away. You still have a small shunt, and then it's ultimately closed. We don't know that. We have shown, people have shown that this procedure is feasible into NICU, so you don't even need to transport the baby in the cath lab. And this is what we all aim to do. And so one day we will also do that in Necker-Enfants, just go to the NICU and not bring the baby to the cath lab. This procedure is feasible without contrast injection. And I think this is important for the baby with severe renal dysfunction when they come to the cath lab. Complications have been described: LPA, stenosis, coarctation, tricuspid regurgitation, but with good knowledge of the device and with improved technical modification of the procedure, I think we will overcome these complications. And it has been shown that we can close PDA in 700 grams infants. In France, because we want to know where we are going, we are running a prospective registry. I cannot show you data because we are still analyzing them, but the goal of this registry, we have several goals of this registry. One of them is to see the demographic, see if there is a modification of the referrals. We all have the impression that because of the results are so good, neonatologists tend to refer babies that they would not go send for surgery. We want to see technical data, see if there are less procedural complication, obviously, but also see the technical modification over time. And I think this is very important for a pediatrician, but for us too. We want to have follow-up data. We want to see how these patients are growing. We want to see their cardiac status. We want to also see the effect of transcatheter PDA closure on bronchodysplasia and neurologic development at 1 and 2 years. And up to now, we have 200 patients that have been included, and we will have the result quite soon. So in conclusion, I would say that it is feasible, and this has been demonstrated by several teams in this fragile population with a very high rate of success. There is no post-ligation cardiac syndrome, and the ventilation is very fast improved after this procedure. Complications obviously remain an issue, and good echocardiographic guidance, good knowledge of the device, and appropriate device selection are the key to overcome this complication. Long-term evolution clearly has to be analyzed in prospective registry to confirm we're in the good direction for these fragile babies. I would like to thank my team, Dr. Meo, who's doing great echocardiographic guidance, Professor Bonnet, who's helping me, and all my cath lab team, also all the neonatologists involved, the surgeons, and obviously all the anesthetists involved. Thank you very much for your attention.
Thank you, Dr. Milani. I'm really sorry for the inconvenience, and I wish you health in the upcoming days. And I believe you have some questions. Dr. Aghay, please.
Thank you very much, dear Dr. Guiti. And I know it was somehow difficult for you to join us in this session. And I want to thank again all of our speakers for their participation in this Congress. There's a question that my colleagues just wrote me now. What are the probable complications of PDA closure in very small infants? What complications do you expect?
So I think you can have complication pretty much everywhere. You can have access complication, but this is this is never seen. The tricuspid valve is fragile, and you can have complication when you cross the tricuspid valve. This is why we have modified our techniques. You can have LPA stenosis or aortic coarctation, and I think with experience and with good echographic guidance, we won't have these complications so much. Usually, if you cross the tricuspid valve smoothly, the patient is really stable throughout the procedure. The patient has to be stabilized before you start the procedure. There is no way to do the procedure if the patient is not well saturated or if he has low blood pressure, because he will not tolerate that. But if the patient has a good blood pressure, good saturation, he's ventilated with his own ventilator, you have an anesthetist ready with you, the hemoglobin has been optimized too, because there is no way you can do this procedure with 7 grams of hemoglobin, then usually it's quite smooth.
Actually, I know you are in Necker, and so you are in a center that has the experience dealing with these kind of patients. Do you really recommend other centers that they do not have enough experience with that? They go for these special intervention, or they prefer to do it with their surgeons? What is your preference?
I think, and I think you can have the debate for pretty much everything, like even for aortic stenosis. It depends of who you have in your team. If you have a surgeon who's very competent, who has excellent results, then why not go for a surgeon? But if you have a cath lab doctor who says that, who's confident with small kids, and obviously I would not tell him, okay, you can close a PDA in a 5-kilo baby, just go and do it in a 900 grams. You can, gradually decrease the weight, and if you're confident, why not starting a program? But this depends of who you have in your team.
Thank you very much. I got it. Thank you very much. I'm so thankful for your support of the Congress. And if there is any questions, you can go for the cath lab, and we will write it down in the chat section, and then you can check it for us and answer it. Thank you very much, Guiti.
Thank you very much. Thank you. Bye-bye.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.
So shall we proceed to the discussion with Dr. Valverde? Dr. Valverde, please, if you have greetings, and then I will share the pre-recorded session.
Okay, hi everybody, and thank you for attending. Yes, and hi Seville, please go ahead with the pre-recording session if that's okay.
Yes, of course, it's okay.
So hi everybody, and thank you for attending this session. It's a pleasure being here with you. So we will discuss today about the role of virtual reality and 3D printing for planning intervention in congenital heart disease. I have no conflicts of interest, so we will discuss about the potential of 3D printing in both percutaneous intervention and also surgical planning, and we will also explore the application of virtual reality. And what about percutaneous interventional planning? So one of the first things we need to discuss is about the accuracy of 3D printing. So we evaluated over 320 anatomical structures, and what we found is that 3D printed models are really accurate replicas of the cardiac anatomy with a mean bias below 1 millimeter of difference. And also another thing we need to explore, it's about the distensibility of the 3D printed model. And as you can see here in this test we perform, 3D printed models are able to open at the same nominal pressure that compared to conventional balloons, and they don't burst. So we can achieve that using a wall thickness of 0.4 millimeters using polyurethane. And also with different materials, like, well, for example, Tango, we can also simulate the opening of percutaneous valve implantation and valvuloplasty using low pressure balloons. This is one of the first studies we performed, where we had a patient with aortic arch hypoplasia, we were considering using a stent here. The problem is, if you use a big stent, you may occlude the circulation to the brain. So if you use a small stent, you have no issues with the blood flow through the brain. However, you may have low grip and migration of the stent. That's why we started using 3D printed models to simulate the percutaneous implantation of a stent. And as you can see above, this is the example what we did with the 3D printed model, and just below, the same reproducibility in the patient. And another application is using percutaneous pulmonary valve implantation. This is a patient with a huge right ventricular outflow tract, which was wider than what we would expect for using a melody valve implantation. So because of the right ventricular outflow tract was around 36 millimeter, that's why we consider using an under-stent balloon for the melody valve, and we also use another Palmas Genesis stent 12 millimeter balloon to create like a landing zone for the previous stent. In the first one, we will implant a melody valve. In order to avoid regurgitation, we occlude the second stent using a vascular plug. So the blood flow will go through the melody valve and will not return back. This is what we simulate on the left. This is the 3D printed model, and on the right, this is the same intervention performed in the patient. So as you can see here, we inflate both balloons, and also the second balloon, the second stent is the stent which create a landing zone for the under stent expansion up to 24 millimeter, and then we can implant the melody valve inside the first stent. And as you can see here, it's a truly competent valve. Okay, and another application is evaluation of coronary artery fistulas. One of the main things we wanted to explore, it's about the increased learning using 3D printed model compared to 3D volume render. But for that, we asked interventionalists to describe coronary artery fistula based on raw CT images. Then we also give them the possibility to explore the 3D volume render view. And finally, they could evaluate the 3D printed model, where they could also perform the intervention. And what we saw is that the same intervention that we were planning using the 3D printed model is the same intervention that they can perform in the patient. What we found is in the 4 patients with coronary artery fistulas, 3D printed models always added some information. However, in the 3D volume render, to be honest, only in 2 of them, they really added some information. Another example and application of interventional planning of 3D printed model is in partial anomalous pulmonary venous return with atrial septal defect. One of the hypotheses was that using a covered stent in the SVC, it will allow the blood flow to continue back to the left atrium. However, it's a risky procedure. That's why we start evaluating the 3D printed model to replicate the intervention. And finally, we were able to replicate this intervention in 4 patients without the need of surgery. Our colleagues from the adult cardiology, they asked us to have 3D printed model to simulate closure of left atrial appendage closure using different devices, and it was always a success, as well as the paravalvular leak. We can evaluate the 3D printed, we can simulate the intervention of paravalvular leak closure using 3D printed model, using imaging fusion. We have been also exploring the possibility of using 3D printed model for training of complex intervention. Here you have a phantom with a pulsatile pump. And also here you can see that we can use that for training, for the trainees in workshop. It's very useful to have the trainees, for example, in this case, going through the right heart into the pulmonary arteries and they really learn a lot. And finally, I would like to talk about the 3D printed model for surgical planning. This is the first patient where we perform an interventional planning using 3D printed model in a patient with an Ikeda procedure. As you can see here, this is the view from the surgeon on the left. This is the same view that you have using the 3D printed models. In this case, we also have improved the softness and thickness of the 3D printed models. This is a case where we work together with the colleagues from Montreal in Canada. As you can see, it's a lot of apical muscular VSDs. We design a patch which really include all the apical VSDs, and the same intervention that we plan in the 3D printed model is the same intervention that we perform in the patient. But one of the largest studies we have performed is the international study, including 11 centers all over the world, including 40 patients. All the participant centers sent us the images. We created the 3D printed replica of the heart and send the model back to them in order to plan the intervention. So we included 40 patients with a mean age around 3 years. Most of the patients were complex congenital heart disease like double ocular right ventricle, TGA, univentricular heart physiology. The utility of the 3D printed model is that you can really plan complex intervention using the 3D printed models. This is the result of the study. Initially, 12 patients were decided to go conservative management. However, after evaluation of the 3D printed model, 3 patients were rescued and changed conservative management to either 2 biventricular repair and 1 patient for stage univentricular heart physiology palliation. And in the group where patients were decided to have surgery, in up to 12 of them, they maintain surgical practice plan. However, in 15 of them, they changed surgical plan. In 4 patients, they changed the univentricular heart physiology palliation to biventricular repair. And in 29 out of the 30 patients include, we keep the same identical surgical intervention. So the result of this study is that 3D printed model changed the surgical plan in up to 44% of the patient included. In 15% of them, they changed either conservative or univentricular heart physiology palliation for biventricular repair. And in 20% of them, we refined the biventricular repair to achieve a better surgical correction. We also have explored the possibility of using 3D printed model for medical education. And you can see here Professor Anderson from Evelina London Children's Hospital, and he's explaining a very complex surgery with isomerism. It's really helpful for young trainees. We have a bunch of videos for online education. Finally, I would like to discuss about the potential role of virtual reality for surgical planning. This is the first case where we use virtual reality. As you can see here, we have a large VSD in a patient where initially it was not considered to be able to close because of the size of the VSD. One of the hypotheses that we have is that we were showing a large VSD compared to a small septum length because of the limitation of the windows of echocardiography. That's why we explore using virtual reality, and as you can see here, this is Dr. Hosseinpour from Seville. He's in the virtual world right now, exploring the heart. And here, as you can see,
you cut the heart, and now cut.
So he can cut the heart, see both ventricles, right ventricle, left ventricle,
here's the VSD,
and now he's pointing out where the VSD is.
Here is the VSD.
He can evaluate the size of the VSD, and he can decide whether what's the relationship of the VSD compared to the ventricular septum. So although initially based on the 3D echocardiography views that we provide, it was not considered a good candidate for closure of the VSD. After using the virtual reality, they decide that the size of the VSD was nothing compared to the long size of the septum that he evaluated under virtual reality. We also have improved now, we have a virtual theater. We can use different colors. We can correlate the 3D views with the conventional CT images, echocardiography. So I think virtual reality will be improved over the recent years. So thank you very much for attending this session. It has been a pleasure. So thank you.
Thanks again, Dr. Valverde. We appreciate having this mysterious area clarified. In fact, I was just wow. Actually, thanks from Seville to Seville. So if you guys have any questions, please ask in the chat section. I see one question. If you're ready, I will ask. Where's the question? I lost it.
First, I want to ask my question. Isra, what is the material that you are using there for kind of parts that can be mended outside the body? What is the material for that?
We have tested several materials, and we are using polyurethane because it's a really cheap material. The FDM technology is really cheap, so the cost of a 3D printer using this technology is something like $600. The cost of a small model could be something like $30. So it's a very cheap material, and if you print it with a small thickness, you can do the suture, cutting, scissors. So that's very good.
And how did you manage to work with your surgeons? How did you pursue them to accept the how can I say it, the element of 3D printing? You know, we have somehow difficulties here because we are starting the process in Iran. Okay, it is just at the beginning. So, so it is very important for me to know your experience that Dr. Hosseinpour is going to the theater and he's performing a virtual surgery. And what was your experience with the beginning of this process?
I mean, if Dr. Hosseinpour uses my model, I give him chocolates and you just bribe him. But maybe Dr. Hosseinpour can explain that. To be honest, before he can talk, I think my experience is that it's a very user-dependent. If you have an enthusiastic surgeon willing to explore new technologies, willing to embrace MRI, 3D reconstruction, 3D printing, everything is easier. Some surgeons may argue that they don't really need a 3D printing because they are a 3D printed model because they can do things. Of course, I will not print an ASD closure for Dr. Hosseinpour because he can do with his eyes closed. So it's finding an enthusiastic surgeon and finding the adequate congenital heart disease, which is so complex that it really helps him. But maybe Dr. Hosseinpour can take. And
what is your experience, Reza?
Maybe I can add. It's many of the things we do in life, we think we decided doing them. In reality, other circumstances made the decision for us. And we just think we're making the decisions. We do no such thing. When this project developed, I was in a very tough situation. It coincided with the times when we were starting to do the Nikaido operation in Seville. At that time, there were only 2 other surgeons in the whole of Europe who had done Nikaidos. One of them had done it 3 times, and the other one had done it once. And I was starting to do them not because I particularly wanted to, it was quite stressful, but because we had a group of patients that had accumulated in Seville. When I first came from England to Seville, there were like 4 or 5 patients that nobody dared touch. They needed Nikaido operation and nobody wanted to do them. So they were there and suddenly they became my problem. And I did those operations and suffered tremendously. As you can see, I have a lot of gray hair. I'm not that old, but it was very stressful. And then Israel came to me and said, look, Reza, would it help you if I can give you a model that you can take a good look and practice the operation on it before you do that? It was like a gift from heaven. You know, now you're saying a nice surgeon who's cooperative. I was neither nice nor cooperative. I'm definitely not nice. I'm a cardiac surgeon. So by definition, I'm not nice. And I was not cooperative. I was desperate. Israel came to my rescue and made that Nikaido project smoother by giving me beautiful models. Because you see, when we started doing Nikaido operations, we were suddenly seeing the heart from the angles in which we had never seen before. And we had no idea some of the corners of the heart, what they were actually going to look like. And you don't want to find that out in the middle of an operation with the aorta cross-clamped on bypass, you know? So I had no choice but to be cooperative. In fact, we were all very nice to him. We're still very nice to him because he produces these things that we need. And he made that possible. Now, since then, our Nikaido project has taken off, and I'm now used to doing Nikaidos. It's no longer a challenge. But through that project, we realized that this technology is so useful for so many other things. And if I may specifically mention one pathology, it is double outlet right ventricle. Double outlet right ventricle, as you all well know, is not one condition. It's a spectrum of conditions, infinite in numbers. They all vary in size of the VSD, commitment of the VSD to the aorta or to the pulmonary artery, and lots of other minutiae of detail there. And it is very difficult to decide what to do, to plan the operation beforehand, or indeed to decide whether this is going to be biventricular or univentricular. So we started using the 3-dimensional models for that purpose. Or a particular VSD, is that too big to close? Is that a univentricular heart? Or is that repairable? Is that septatable? All of these things, the 3D models came in and helped, and we have a very low threshold to ask for one. The minute there is any doubt at all, we ask for one. But let's be very specific. The questions that are difficult to answer almost invariably come from variants of double outlet right ventricle, or size of VSD, or whether there are multiple VSDs, or can we close that, or do we have to band? I don't remember, do we still ask for it for Nikaidos, or do we just do the Nikaidos? I don't remember anymore. We do it, Nikaidos are small in number. So, but double outlet right ventricle is not. Multiple VSDs are not. So it is an extremely useful tool, which does, I have to admit, does make me lazy. I have stopped making a great effort to understand the echo pictures. I just look at Israel and say, just print me a model. You know, it's made me lazy. Before, we used to really squint at the screen and go and sit with the cardiologist doing the echo and say, well, why don't you cut it that way or this way? Show me this, show me that. And we would end up thinking, sitting down, talking, having lots of meetings, fighting amongst ourselves to decide whether we're going to do this or that or the other. Now we've stopped doing that. I just look at him and say, give me a model and we'll decide, you know? So it does make you a little bit lazy. It's a bit reminiscent of what happened to cardiologists when echocardiography became widely available. Before, cardiologists were magicians with the stethoscope. Now, people just do an echo. So, you know, you become lazy.
Thank you very much. I should say that actually you are very handsome, and my friends here, they are all share same idea with me. Just the last question from Israel. What is the option for you to make a 3D print from the heart? Is it 3D echocardiography or is it CT scan?
No, we always, I think the golden rule is do the imaging technique that you are good doing at your center. Mm-hmm. So if you have expertise in CT, go for CT, no doubts. If in your center you have expertise in MRI, of course I prefer MRI because I was trained in MRI because of the radiation risk, but it's more complex. But if you are good doing something, that's what we need for 3D printing. Now we are also working on the imaging fusion with 3D echocardiography, and we have published hybrid imaging combining MRI and echocardiography, but it's more time consuming. So I think the hybrid models combining MRI, echocardiography, CT and echocardiography, I think we may need a couple of years for the technology to be quickly and be done semi-automatically. But that's the future for sure. So we will provide 3D printed models containing the whole anatomy, valves, subvalvular apparatus, great vessels.
Thank you very much. Thank you very much, gentlemen. Because of the shortage of the time, we should go for the next and the last presentation, but of course not the least. Thank you very much for your participation, dear Reza, dear Israel. It was a great discussion with you, and I do really enjoy that. I'm sure that other audiences also enjoy the discussion between us. May see you soon, and thank you very much from us.
My pleasure.
Thank you. Thank you.
Bye.
Thank you so much. And actually, I am so jealous of you cardiologists. Maybe someday I will become one. So now it's time to ask Professor Sarah Badran to join us with her speech. Professor Badran, I think we will play your pre-recorded session, or if you're with us, could you please have greetings with us? Yes, I will. Okay, so I will play the pre-recorded session.
Good evening. Assalamu alaikum. My name is Sarah Badran from Keck School of Medicine of USC and Children's Hospital Los Angeles, and this session is on the management of aortic stenosis. So why talk about the aortic valve? Left ventricular outflow tract obstruction. Any blockage in the left ventricular outflow tract of getting the blood from the LV into the aorta makes up 6% of congenital heart disease in children. Valvar is the most common, where the valve itself doesn't open, but you can have subvalvar, where there's a lesion under the valve, or supravalvar, where there's narrowing above the valve. We're going to touch on all of those. The natural history lets us know that there's significant morbidity and mortality, and of all of pediatric sudden death, 10% is from aortic stenosis. It's progressive. It often starts in childhood, and you might not need anything done until you're an adult, but it really doesn't get better on its own. The anatomy is very complex. Tight, fibrous annular ring with 3 commissures, 3 cusps. But the cusps are kind of complicated structures. Look at the nodule, the way the fibers are arranged. They have to close just perfectly to prevent leak and open completely out of the way when they're opening. And it doesn't have any of this fancy sort of chordian papillary muscles like that the mitral valve has here. It's just the cusp with a little bit of support into the wall. The cusps are named for the coronary arteries that are off of its sinuses. So this one here is the right coronary cusp, because the right coronary artery comes off here, left coronary cusp, and this is the non-cusp, the non-coronary cusp here in the back. And the posterior wall here is attached to the anterior leaflet of the mitral valve. All that's summarized on this slide. But the point of it was to make you realize how complicated the aortic valve really is. So even though a perfect aortic valve is preferable, they are complex structures, not easy to repair. Replacement options are limited because of the size of the kid, the size of the valve, needing warfarin, etc. So we have to stress the function over the structure. If it works, it really doesn't matter if it looks funny. And we're going to work with it, use medical management, and only go to surgery if it's absolutely necessary. That means we have to really understand the function and the cardiovascular physiology really well. This is a slide to remind you of where the aortic valve is. It's right here. It is the valve that lives between the pump and the pressure reservoir. By pressure reservoir, I'm giving you this tracing here, showing you that the aortic pressure is 120/70, and it's this pressure that drives the flow through the cardiovascular system. It drives it through the aorta, arteries, arterioles, capillary bed, dumps the blood into the veins, and the pressure at this point is almost zero before the right ventricle can pull that up and try to push it, force it through the lungs so you can preload the left ventricle again. What's that got to do with basketball? I hope this analogy helps. If you think of this basketball as full of blood and under a lot of pressure, okay, that's your pressure reservoir, and I make some holes in it, then the blood's going to come spurting out, just falling out of there. It falls out of there into this sort of situation where it's kind of hard to get through. It fights through and it finally makes it, and it just dumps at the end. It's all out of pressure now in this big lake of fluid. In the meantime, this little basketball is all out of pressure, so it needs a pump to refill it. So it's the pump that's trying to keep up and keep that ball full of pressure, even as the blood is leaving it all the time. How is that pump going to fill? It needs to have a body of fluid near it, and it's drawing out of that in order to suck it out of this area and push it into that ball. And how is this fluid going to get here? You need another pump that pulls it out of this big sort of lake of fluid that's just sitting there and force it into this body of fluid so that it's available for this pump as soon as it's ready to go. So here we go. This is the aorta, your pressure reservoir that's driving the blood forward into your muscle, your brain, and your kidney, etc. Your capillary bed, your venous reservoir where all the blood is stored before it can get pulled up from the right ventricle, pushed into the lungs so that it's just waiting there and ready in the left atrium so that the left ventricle can fill really rapidly and then refill the pressure reservoir, and round we go. So why am I using this analogy? I want to make the point that this is the aortic valve right here. And if it's stuck and you can't get the blood adequately into the aorta, you have problems with systemic flow and oxygen delivery to your organs. So if you want to start with oxygen delivery, let's say you have your little kidney here saying, I didn't get enough oxygen. It's going to complain. And the neurohormonal controls in the autonomic nervous system are going to try to get it more oxygen. So it's going to say, I need a more heart rate and more respiratory rate, right? Just because it needs more oxygen. So you're going to have tachypnea and tachycardia just on the basis of that. What if you're not able to get enough blood into your aorta through that valve again, and you can't get enough blood supplied to your muscles, your kidney, your brain? If your kidney's not getting enough blood, it's going to shut down a little bit. Maybe you don't have as much urine output. Maybe your brain, maybe you get a little bit dizzy. Maybe you have indigestion. So all of these would be symptoms of decreased cardiac output. The last of the symptoms I want to talk about is cardiac reserve. What if you are kind of feeling okay? Let's say you have a fair amount of blood, the stenosis, the narrowing is not that bad, and then you want to run, which means you want to pour tons of blood now into your muscle, for example. So now the blood's going to be pouring out of that ball. You need to have a pump really, pumping really rapidly and easily to keep filling that up and compensating. But if you can't, because the valve's stuck, then you have no cardiac reserve. And you're not able to increase your cardiac output for activity, and so you get exertional dyspnea. So that's on that side. What about on the back end? So we talked about, fine, you can't get blood into the aorta, but now we're saying the blood is actually backing up here in the left ventricle, backing up in the left atrium, backing up in the lungs, backing up, causing RV hypertension, and maybe RV failure. So you have pulmonary congestion and systemic venous congestion. So this is a summary of looking at all of that together and saying if the aortic valve is a problem right here, not only do you have problems getting the blood into your systemic circulation and driving the blood appropriately forward, you also have a problem with the blood backing up, causing pulmonary congestion and systemic congestion. And this is a summary of how all of those things will lead to the symptoms and signs that you see on your patients. Okay, back to valve disease now. So for valvular aortic stenosis, most of the valvular aortic stenosis we see is bicuspid. There are various prevalence studies, one in kids looking at echo and one in adults looking at autopsies. So the prevalence is somewhere between 0.5 and 2%, more in males. And it is, again, progressive. The older you get, the more likely you're going to need an intervention. The genetics of aortic stenosis is really interesting. It's not completely clear, but there are familial clusters and there are some known associations with various syndromes. So Kabuki, Jacobson, Turner's, Loeys-Dietz. And looking more in detail at the bicuspid valves, right, left, and non-cusps, fusion of the right and left is the most common form of bicuspid aortic valve, but it's fusion of the non and the right that has the higher risk of getting aortic insufficiency or aortic stenosis, so we keep a closer eye on that. It can be associated with a dilated aortic root, which, by the way, is not related to the degree of stenosis, so you can't really predict who's going to have that. And sometimes there's other associated lesions like coarctation or a VSC or a PDA. Let's talk about the aortic stenosis pathology now. So if the valve is stenotic here and the blood is here in the left ventricle, the left ventricle pressure is going to go up, which means the wall is going to get thicker. So that's the first thing that's happening on that end. On the other hand, you have not as much blood getting into the aorta. So in the aorta, the pressure is going to drop. The stroke volume is going to drop. Those things are going to cause an increase in your heart rate to compensate and an increase in your resistance. Now, why is an increase in a heart rate such a big problem? It's all about the coronary arteries. So remember now, the coronary arteries come off here from the that sinus of Valsalva to fill the muscle. The coronary arteries fill the muscle in diastole. So you want to have a nice long diastolic time. Because the heart rate is up, your coronary arteries are now maximally dilated. They're as big as they can be because they don't have a lot of time to get the blood into the muscle. Now, on top of that, now your left ventricle got really thick, so you need more coronary blood flow. So you have a maximally dilated coronary artery, much thicker muscle, and it just can't keep up. So then you start having microinfarcts, subendocardial ischemia, and it becomes scarred, fibrotic before you ever have LV failure per se. So the left ventricle is still squeezing very well, but you're starting to see fibrous tissue and scar buildup. And that makes the ventricle unable to relax, which increases the diastolic pressure, which increases the LA pressure, which can increase the pulmonary pressure, etc. So the signs of left heart diastolic dysfunction are going to precede actually the systolic dysfunction. That's summarized here. So what are the symptoms like? If you have mild aortic stenosis, most of those kids are obviously going to be asymptomatic. If you have moderate disease, they're going to look okay unless they try to exercise, and they won't be able to increase it, so they have no cardiac reserve. They're going to have exertional dyspnea, and because they're already starting to run out of coronary flow to their muscle, they might have angina as well. The severely stenotic kids are going to have symptoms very quickly, and they're going to have all of the symptoms we talked about in that first component when we were talking about how not only do you have decreased cardiac output, with all the symptoms of the organs that are under perfuse, you're going to have decreased cardiac reserve. You're not going to be able to increase your cardiac output as needed. You're going to have both tachypnea and tachycardia because you have decreased oxygen delivery to your organs. You're going to have pulmonary venous congestion because the blood's backing up into the lungs, and you might even have right heart failure and systemic venous congestion if the stenosis is bad enough. The physical exam for valve right aortic stenosis in an older kid with mild aortic stenosis, they're going to look fine, normal vital signs. The murmur, as you know, in the right upper sternal border that radiates to the carotid, and there's a systolic ejection click, so that's on this diagram here. And as it progresses to more severe, the ejection click disappears, the murmur becomes louder, harsher, and longer, and you become more tachycardic, more tachypnic, you start having rales, the pulse is barely keeping up, so now its pulse is parvus, it's very weak, a tardus, it's delayed. You can have a thrill in the base and the suprasternal notch. And for those of you who really are into physical exams, realize that S2 begins to narrow, and then it becomes a paradoxical split. Diagnostic testing, the EKG is going to show LVH and strain. And then on the echocardiogram, you're going to look for the gradient between the LV and the aorta, look for aortic dilation, look for the diastolic dysfunction in terms of strain measurements, and any other associated lesions. I only put this slide on because I want you to understand that we use the mean echo gradient, and you might get a report that says the gradient across the aortic valve is 80 millimeters of mercury peak and 40 mean, something like that. It's the mean that is more likely to correspond with a direct measurement by catheter between the left ventricle and the aorta. Looking at it on this diagram, I'm looking at this. This is the Doppler signal across the aortic valve. The peak is here, but the mean would be, the area under the curve. Using that number, that's how we grade the aortic stenosis. So mild means the gradient is less than 20, moderate is 20 to 40, and severe is more than 40. The preload and function and afterload really affect the gradient, so it's a little bit important to know. If you have, for example, just way more blood than usual in the left ventricle that you're putting through the same narrowing, more blood going through a small narrowing, it's more congestion, it's going to give you more of a gradient. So you're exaggerating the gradient, for example, if you're anemic or aortic insufficiency or something where you just have more blood in the left ventricle. And if you have less blood going through the obstruction, so for example, you have decreased cardiac function and the muscle is really weak and it can't put the blood through, that is going to underestimate your gradient. This is a slide, I try to put everything on this one page because I think it's helpful this way. So if you have symptoms, exertional dyspnea, chest pain, angina, whatever, and the gradient's more than 40, you need to intervene. Restrict them and fix the valve if you can. On the other hand, if you have no symptoms and the gradient's under 20, you don't do anything. Those are easy. It's the ones in between that are more work. So if you have no symptoms with a moderate gradient of 20 to 40, you're still probably not going to do anything, but you're going to watch them very carefully. And if you have no symptoms but a high gradient, you really have to watch them really carefully. Those kids are higher risk of really developing angina and permanent changes and scarring, etc., in their ventricle. So you need an excuse not to intervene. So you're probably going to intervene sooner rather than later on those. Medical management, then, you're managing the signs of heart failure. If they are mild, you're going to see them every few years, but if they're moderate to severe, you're seeing them every few months. Control their hypertension, control their heart rate. You're probably going to use atenolol, helps to avoid the root dilation. And of note, SBE prophylaxis is not indicated unless you've had a prior infection or actually you've had a valve replacement. The therapy for valvular aortic stenosis is going to be a transcatheter aortic balloon valvotomy. This is your default therapy. You can see the catheter coming through, the valve, you inflate the balloon, stretch the valve, take the balloon out, and that usually helps. Acutely, good acute success, but most patients are still going to need something else over their lifetime. Surgical options, I listed a whole bunch here. Commissurotomy, dividing the raphe, making the leaflet thinner by debridement. It works pretty well in dysplastic valves. They very rarely get insufficiency from it, though sometimes they'll have residual aortic stenosis. Valvar replacement, we really try to avoid that in kids. But if you're going to do it, we don't use mechanical valves unless they're older teenagers, really. It's more durable, but they need warfarin, and they're going to outgrow it anyway if they're small. So bioprosthetics are better for little kids. They don't need warfarin, but they're not as durable. And then there's all this research in transcatheter valves, and I really hope the next time we talk, we have something that we can put it with a catheter in children, but we don't really have anything for kids right now. So now talking about valve reconstruction, this is really mostly where the focus is. There's something called the Ozaki procedure, which we haven't done much at my hospital, so this is mostly what I learned by asking other people. It's the replacement of the cusps of the aortic valve using autologous pericardium. So they take the kid's pericardium and they have a template where you trace out the size of the cusps that you think you need, and you cut them out and you literally sew them into the aortic root. Voila. So, but we at my institution, we still mostly do the Ross procedure. And that means you want to use an autograft. You want to put a valve into the aortic position that belongs to the kid. He's not going to reject it, and it's going to grow with him. So you take the pulmonary valve, you cut off the pulmonary valve, cut off the aortic valve, throw away the aortic valve, take that pulmonary valve, stuff it in the aortic position, reimplant the coronaries, and then put a conduit between the RV and the pulmonary artery. Now, Ross procedure, then again, it's an autograft. Best for small children, those who cannot use Coumadin. That conduit that we just stuck between the RV and the PA, this little thing here, is at some point probably going to need some sort of intervention. Okay, now we just have a few minutes to talk about subvalvar and supravalvar AS. Subvalvar AS is the second most common type of outflow tract obstruction. We're talking about a blockage right here under the valve. Sometimes it should be right, sort of not exactly on the valve, but sometimes it's on the valve and can actually creep onto the aortic valve and cause aortic insufficiency. Sometimes it even creeps onto the mitral valve and can cause problems with that. It's more common in males. And it is also progressive. It seems to sort of run in families. If you have a predisposition to having it, maybe the septum just sticks out a little bit, and so it makes it more likely the way the flow is moving to kind of develop that membrane. And so, again, it can be, develops over time, familial predisposition. Sometimes it's rapidly progressive, and sometimes it's barely changes for years. It has various things that can be associated with. So, for example, if it's growing on the aortic valve and causing insufficiency, you might need to operate on it sooner rather than later. So you look at any other associated lesions. And the most interesting thing on physical exam from this murmur is the way it directs the blood. It causes this kind of weird high-pitched shrieking systolic ejection murmur that decreases with Valsalva, as opposed to in hypertrophic cardiomyopathy where it increases with Valsalva. So that's an important physical exam thing. In terms of how to take care of it, the problem is that there's a very high incidence of it recurring, 20 to 30% recurrence if you operate within the first decade. Again, probably because of that predisposition of the way things are formed. So you observe only if it's less than 30 millimeters of mercury with careful follow-up, surgery only if it's over 50 millimeters of mercury, and if it's between 30 and 50, you just watch it and try to postpone surgery until they're over age 10, unless there are other issues in terms of you think it's starting to affect the aortic valve, for example. Couple of slides on supravalvar aortic stenosis. This is the least common LVOT obstruction. It's an elastin arteriopathy, as you know, associated with Williams syndrome. This is how the elastin is supposed to look in the arteries, with the elastin helping to form the elastic lamellar units. And there's something about it when that's missing that makes the arterial walls really thick. We don't know exactly why, but we think maybe because they're not as strong, the muscle compensates by hypertrophying, and that's why the walls get so thick. Regardless, this is the classic sort of hourglass where there's a discrete constriction right above the valve, but sometimes it's very long segment. It can be in the renal arteries, it can be in the coronary arteries, etc., and it tends to worsen over time. This is what the Williams syndrome children generally look like. As I said, it can be in the coronaries or the renals. It can also affect the aortic valve in a few situations. And really curiously, the pulmonary arteries often are affected also in Williams syndrome, but those improve with time. And again, you can also have other associated lesions. With supravalvular aortic stenosis, a couple points. There's still a systolic ejection murmur, but unless the valve is affected, there's no systolic ejection click. And curiously, there's this Kawanda effect, which gives you a higher blood pressure in the right arm than the left. And this is a paper from 1970 showing how that happens with the way the blood is directed through the valve. It hits the wall and kind of prefers the right side, and therefore gives you right-sided hypertension. The other reasons for hypertension, really, you can have renal artery stenosis, you can have a coarctation, and just the decreased elasticity per se in the wall means that when the pump ejects into it, if the wall can't distend a little bit, it just kind of hits the wall and gives you a very high systolic pressure. The treatment for supravalvular aortic stenosis, now, it's a much higher risk surgery than either valvar or subvalvar. But we operate with a gradient of, if it's just over 30, so we have a lower threshold. And that's because of our fear of knowing that it's progressive, it can affect the coronaries, so we have a lower threshold for fixing it. We fix it with this kind of, you slice open the supravalvular area, you might have to open into one of the coronary arteries to fix that as well, and you do these bifurcating patches to really open it all up, and that seems to work. So in summary, aortic stenosis, whether it's valvar, subvalvar, or supravalvar, makes up 6% of congenital heart disease. There's significant morbidity, progressive throughout lifetime. It causes decreased flow to the aorta and the systemic organs, and has back pressure buildup in the LV, LA, pulmonary artery, RV to the systemic veins. No great treatment options, so we still need to manage symptoms medically and watch carefully for as long as it's safe. And we hope that one day we have better interventional options. Thank you for your attention. I'm looking forward to seeing you in person and receiving your questions.
Thank you so much, Professor Badran. It was so educational. Let's see if there are any questions in the chat section. Okay, I believe there are no questions in the chat section. So from each and every one of us here at Children's Medical Center, Tehran University of Medical Sciences, we would like to say a particular thank you to Dr. Hosseinpour, Professor Badran, Dr. Valverde, and Dr. Milani, whose support we are honored to have. And despite the time difference, we were more than happy to get involved. A special thank you goes also to our fantastic audience. Again, if you want to receive a certificate of attendance in this Congress, make sure to register on our website, reserve a seat on your desired panel. For our Iranian audience, if you want to receive CME credit, don't forget to participate in the quiz panel and in maximum of 2 days in the site of cmequiz.ir. Don't forget to follow our social media pages and YouTube channel to stay updated on our next events. Unless there are any other questions, I want to thank you everyone who has participated on today's call. Thank you for your patience. For our next event, our upcoming virtual conference, the Rheumatology and Pulmonology session, will take place here in this hall in 5 minutes. We look forward to seeing you at this meeting, and we're sure you will find it an outstanding educational opportunity. Again, thank you everyone for your patience. We appreciate your continued cooperation with us. Please submit your questions to us on our social media if you have anything as that you thought of after we conclude today's session. We will make sure to answer those questions. Thank you. Have a good day. And now I'm going to announce the next session in Persian for Iranian audience. ما تا 5 دقیقه دیگه تو همین سالن سشن روماتولوژی و پولمونولوژی رو داریم. حتما با ما باشید، خیلی سشن باحالیه. مرسی که با ما هستیم، منتظرتون هستیم تا 5 دقیقه دیگه.
مرسی. مرسی از همه. Thank you very much everybody. Thank you very much. See you soon. Bye bye Reza. رفت. دکتر خیراندیش اومدن.
هستم بابا، من دارم گوش میدم. دستتون درد نکنه، خیلی تا الان خوب پیش رفته. دست شما درد نکنه.
Hello everyone and welcome to the 32nd International Congress on Pediatrics. In today's webinar agenda, we will be covering rheumatology and pulmonology session. We invite physicians around the world to join us and share their valuable experience with us. This is the fourth day of our online webinar and we're happy we were able to perform it in a timely manner. I hope you haven't missed those 3 days. If so, don't worry because you have access to recorded sessions on our website. I am Dr. Azin Qamari, a medical doctor from Tehran University of Medical Session and the manager of this panel. I would like to introduce today's panelists. We are so happy to have Professor Leyla Khirandish Gozal with us with the affiliation of tenured Professor of Pediatrics, Children's Miracle Network endowed Professor of Child Health, Director, Child Health Research Institute, Department of Child Health, University of Missouri, United States of America, on the subject of a sneak peek into the future of the sleep medicine. Professor Vasilios Panos, NICU and Periculture Department, University of Cagliari, and Italy on the subject of gut and lung microbia in acute respiratory failure disease. Professor Sarah Badran, a medical doctor, co-director interventional cardiology, Children's Hospital, Los Angeles, on the subject of heart in Kawasaki disease, what a pediatrician should know. Professor Angelo Ravelli, Professor of Pediatrics and Director of Pediatric Residency Program, University of Genoa, if I pronounce it correct, Division of Rheumatology, Giania, and Italy, on the subject of classification criteria for macrophage activating syndrome complicating systemic juvenile idiopathic arthritis. Professor Sujit Singh, Department of Pediatrics, Head of Allergy and Immunology Unit at Advanced Pediatrics Center in PGI, India, on the subject of Kawasaki disease on Chandigarh, North India, our experience over 26 years. I would like to take a moment to thank our speakers, our dearest panelists for joining us today. I would also like to take this opportunity to thank Vice Chancellor for Global Strategies and International Affairs, Directorate of International Relations of the Tehran University of Medical Science, for giving me the privilege to patron this important event. I also would like to thank our dearest audience for joining us this event. And I gotta tell that we weren't here if it wasn't for Dr. Ziai and Dr. Aghay Muqaddam. Thank you so much for making this happen for us. Dr. Aghay wants to have a few words with you. Professor, please.
I would like to thank all of our guest audiences for participating in this session. It is our great honor to have you with us. And thank you again. Let's start.
Just a few reminders before we get started. This webinar is broadcasting live on YouTube. A recorded version of this webinar will be available on our website too. Information about our social media is provided in the chat section. Due to the number of participants, please make sure that you have muted your microphone during the lectures. And if you have questions, we encourage you to ask them by the chat section. And there's a webinar tool called Raise Hand that you can use, and we are aware that you have any question, and we will answer your question at the end of the presentation if we have enough time. If you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. For Iranian audience, if you want to receive the CME quiz, CME credit, don't forget to participate in the panel quiz in maximum of 2 days in cmequiz.ir. And don't forget to follow us on the social media pages and YouTube channel to stay updated our next events. And with that, we will open today's webinar. We are very lucky to have with us Professor Leyla Khirandish Gozal. Professor, we are all ears. Thank you.
Dear Dr. Gozal, dear Dr. Khirandish, hello and greetings from Tehran. Do you prefer to go with your pre-recorded session, or you prefer? Okay, okay. So may I ask for a few words from you, and then we will start it with the pre-recorded session.
Absolutely. Thank you very much, Dr. Aghai. I'm very, very honored, and I'm really thrilled to be part of this panel, elite session of such amazing speakers. I'm very honored to be here. I never thought that I would be able to actually speak to my own colleagues in my own country, far, far, far away, in such a wonderful and amazing way. Although we are all kilometers away, but we are all sitting next to each other and talking. Thank you for this effort. This is amazing. Sadly, that the virus is keeping us separate physically, but obviously the science keeps us all together. So I am hoping that this would be a very good beginning for all of us scientists and physicians, because our aim is to spread the knowledge wherever we are, however we are, together, and help children and adults who need our knowledge and help. I would be very happy and honored to be in this session. I hope that my small contribution would be useful, and I am very honored and ready to answer any questions if there is any, whether after this session or by email later on. And thank you for having me today.
To the speaker for the 32nd International Pediatrics.
3, 2, 1.
Thank you very much for this wonderful invitation. I'm very pleased and honored to be the invited speaker for the 32nd International Pediatric Congress for Tehran University. My topic is to take a look at what is the future for sleep medicine, and I'm very, very happy to be today with you. As you know, sleep apnea is usually associated with multiple physical and social consequences. Many of the physical consequences is also due to the increased obesity that is a known pandemic, as everybody is aware of. Most of the patients that come to the sleep medicine clinic these days are either overweight or obese. Majority of the patients either have hormonal changes, dyslipidemia, insulin resistance or unbalance, higher blood pressure, inflammation, systemic inflammation, and vascular dysfunction, and many of them have excessive sleepiness. By the same token, they have social problems, they have lower competencies, they have poorer attention and memory loss, and overall, they have lesser life quality. Now, I would like to touch base on neurocognitive consequences, which is quite important, and frankly, it is very important to me as a mother of 2 children. We know that children are in a specific age of about younger preschool and middle school are at the window of opportunity for brain growth and development. Now, it is very well known that obstructive sleep apnea in a very younger age is very, very specific due to the enlargement of adenoids and tonsils, and luckily, it is very easily recognizable by loud snoring and is easily treatable. Now, in an older age as well, sleep apnea is quite common. About 40% of adults with snoring have obstructive sleep apnea and is also treatable with CPAP or BiPAP. Now, what is very important is for many, many years, it was thought that obstructive sleep apnea or snoring was just a sound from the upper airway. Everybody thought snoring is just a sound. Nobody ever thought that it had anything to do with the brain. If you look at this study, I put it on purpose here because this was a real cornerstone of many, many studies that later on was published, and it really set the base for everybody to understand that there is a connection between the brain function, the memory, and the sleep apnea. This study was done by David Gozal when he was a younger fellow back in '98. And this study was a very low cost, no budget study. He had the curiosity to look at whether or not children with low school performance, if they had a sleep apnea and they were treated, did they have an improvement in their school performance? So he basically went to the first graders in multiple schools and asked the teachers to the worst students in the class. Now, this was a very odd question because usually when you go to a school, you ask the best students to be recognized. And teachers were surprised. So he asked for every class in the first grade to show the worst students and asked the teacher to allow them to have their grade cards. The students that were worst academically, they were chosen, and he asked the parents to allow him to have a sleep study for them at home. Then he, based on the sleep study, he recognized the children that had obstructive sleep apnea, told the parents who needed to be treated, and many of those parents that needed the treatment accepted and went for adenotonsillectomy. And some parents decided that, no, my child snores, I snore, everybody snores in our family, and we don't want to do any surgery or treat it. So they decided not to do, so they opt out from the surgery. He came back in the second year of the same school year and asked the teachers in the second year to give him the grades of the same students, both groups that were treated and the groups that the parents decided not to do the surgery. Both groups had the sleep study in the first time. And as you can see in this slide, I try to point at it. The first grade students that had treatment, suddenly in the second grade, they had a major, significant 6 to 9 times more academic performance improvement. Now, this is not a 1-time or 2-time improvement. This is 9-fold increased performance. This is basically going from failure to almost getting an A or B. This is unbelievable achievement. Basically, this child went from failing the class to suddenly be top of the class. This was almost a revolution in the field because nobody ever thought there was a connection between not breathing, snoring, and being treated and suddenly becoming a better student. Now, moving fast forward many, many, many years later, now we know after many researchers, many different groups, including our group working on it, we do know that children that have obstructive sleep apnea have many different problems, both behaviorally, emotionally, and cognitively, compared to children that don't have obstructive sleep apnea. Now, we do know that they have prolonged processing. They have visual, auditory, and attention problems. They have social problems. They have thought problems. They have oppositional behavioral problems, such as you tell them to do something, they don't want to do it, or you tell them not to do something, they do it. They have aggressive behavior. Sometimes they fight somebody at a school. Sometimes they're actually being the subject of somebody else fighting with them. They go to school and they get beaten up by somebody, being bullied, or sometimes they actually bully somebody. They are having verbal comprehension ability problems. One of the very quite obvious issues that they have is they act as if they have ADHD, but they're really not ADHD patients. And most physicians make the mistake of thinking this child has ADHD and give them medication. And the parents come to me and they say, my child behaves like ADHD, is receiving ADHD medication, but he's not getting better. Now, this is a video that I would like you to pay attention. This is almost less than a 2-year-old baby. As you can see, this very intelligent child is using his executive functioning to plan his escape from his crib. This very happy kid has thought about how he can bring that mattress folded, put his foot exactly the way he should, and then use that to escape out of there. And he's doing it perfectly. And this child, with this very little age, has figured out a way that most children in his age are not doing. Now imagine, this is the use, he's basically making the best out of his ability. That is, most children are not able to do that. Executive functioning is one of the dimensions of our intelligence. There are many other dimensions, but you would be surprised to know that if this child snores and have obstructive sleep apnea, he would have deficit, problem using his executive functioning. This is a problem solving. So this child uses his brain, uses his ability to solve a problem. Now, we know that if your sleep is fragmented, for example, a doctor that is having multiple phone calls in one night that he's sleeping, let's say every 2 hours somebody calls him. The next day, he cannot pay attention. He has attention deficit. That's a patient that has sleep fragmentation. On the other hand, somebody who doesn't have a sleep fragmentation but has a very, very severe apnea, hypopnea, or has a lot of low oxygen, next day he has bad behavior. He doesn't have an attention problem. He actually acts in a mental processing way. He basically doesn't remember things. Now, these are based on the research that are for many years had been worked through our group and other researchers. Now, to show you one example of the studies we have done, this is a study that I designed about almost 10 years ago. This was a simple study, but very clearly shows if you get a group of children that are coming to have a sleep study, we don't know if they have obstructive sleep apnea or not. We just have them look at a bunch of pictures of animals that are simple for a child of younger age to remember. Let's say cat, dog, horse, very simplistic pictures of animals. They're all identical. And then we close the book and say, hey, do you remember what animals we saw? And then the child needs to remember what he has seen. So the first time out of, let's say, 25 pictures, the child may remember 10 of them. When you open the book again in the next trial, the child remembers this time maybe 15 of them. With the third trial, the child learns 17 of them. So by the last trial, the child learns almost 20 or 21 or 2 of them. Now, these multiple trials, which is learning curve, allows any child to learn to the maximum they can. Now, we repeated this until each child reached his best. Now, that was what we call a short-term memory. And then we allowed basically a maximum score for each child, basically to reach their best they can. And then we allowed them to sleep, and we didn't tell them we're going to come back the next day. So they won't practice with their parents, or they won't practice or repeat with themselves. So they thought the test was finished. But they woke up in the morning, I showed up and said, hey, remember we saw a bunch of pictures and animals? Can you repeat that? So on the right side, you can see in a square, black squares, are the children that actually had obstructive sleep apnea. The children that had obstructive sleep apnea learned exactly the same numbers and exact same animal names, but it took them longer and many more repeats to learn the same animal names and numbers compared to the children of the same age, same sex, and same conditions. But when they finally learned the same thing and they slept, because their sleep was interrupted and it was obstructive sleep apnea that disturbed their sleep, the next day when they woke up, they couldn't remember even the things that they learned perfectly the night before. To make it simple, this is a child that you sit with him, he have, let's say, geography test the next day. It's your kid, is at a school, 3rd grade, 4th grade. You memorize a bunch of capital of cities or world or whatnot, and then he goes to test and comes back, and you know that they learned it, they repeat it at home, you know that they knew it, but they didn't get the full grade. And you say, why? I knew you knew it. Why didn't you get a best grade? Well, what happened? And he said, Mommy, I couldn't remember it, or Daddy, I couldn't remember it. And you don't believe it. You say, why? And the child doesn't know. And they're telling the truth. They couldn't remember it because your child has a sleep apnea and it's not treated because their brain is not functioning the way it should be. Another topic that is super important and I really would like to talk about is empathy. Empathy is how we feel about somebody else's pain. Is our sense of feeling somebody else's miserable feeling or pain or being sensitive to somebody else. Now, it has been shown that children that have obstructive sleep apnea, they are less sensitive to somebody else's pain or sadness. At the beginning, everybody thought that maybe it's just some sort of a psychological behavior. But the truth is, there's a part of their brain in their amygdala that is actually affected. Now, here is a very simplistic picture, but I think this will help. In the middle, you can see a scene. A child's hand is stuck in a car door. Any normal human on the right side, such as hopefully you and me, when we see that picture, we feel that, ow, that's a painful thing. When you feel that, ow, the right amygdala in your brain should be activated. That's where we feel the pain, the empathy, the feeling sorry for that person that we don't know him, but his hand is stuck in that car and it should feel painful. Now, if we are psychopaths, like Hannibal Lecter on the left, not only we don't feel anything, it's as if we saw a bird flying. You don't feel nothing. That's why psychopaths kill people, skin them, eat them. They don't feel nothing. As if they're watching a movie about, I don't know, a leaf falling from a tree. They feel nothing because their amygdala is not activated. Unfortunately, studies, especially in our laboratory, we have shown that in a sleep apnea, children with obstructive sleep apnea have less activity in their amygdala, which probably explains why when they go to school, they get into fights. Maybe because they feel less pain, not physical pain, less empathetic activity is there. So they kick somebody because they don't feel as sensitive to the feeling the other person. Now, this is very important, and I would like you to really pay attention. Just look at the left side. Every yellow color that you see is an actual erosion of a surface of the brain. These are actual images from the functional MRI. These are brains of children that have obstructive sleep apnea. Every yellow part is the part that actually been eroded from the gray matter that from these children had been eroded because physically there's a brain volume reduction if obstructive sleep apnea is not treated. This is really, really important. Most people thought it's just a behavioral thing. It's just maybe an activation or disactivation of something. But this actually tells you that not only you behave differently, you also physically lose parts of your brain. You physically lose parts of your neurons. And we all as physicians know that neurons in the brain are something that doesn't easily replace. Now that probably is why if you are having obstructive sleep apnea and you're not treated, you can lose up to 10 to 12 points of IQ. Now, if you are an intelligent, superior person, like yourself, any one of you in this lecture listening, or your children, if your IQ is about 120, 130, I'm sure if you lose 10 points of IQ, nobody would notice it because you're intelligent already. Nobody notices the change. But imagine you are a person with the IQ is starting already with IQ of 95, and then you lose 10 points of IQ. Now your IQ is to a limit, to a very lower limit. That means this person is not going to be able to go to university, is not going to be able to get a job. He's going to be a burden, he or she is going to be a burden to himself, to his family, and would never have a normal life. This is a major burden on health, on society, on himself, and on his family. This is not something that we couldn't detect, and this is not something that we couldn't treat. If it's something we could have treated, we should have treated it. Now, you may say, how do you want to detect that? Well, very simple. Look at this study about 2007. We showed children that have obstructive sleep apnea and neurocognitive deficit, very simply, their CRP is high. So when you have a sleep study, you have a child, look, the CRP, just a simple CRP from the blood, elevation of that can be a marker of children with neurocognitive deficit. So please, when you are doing a sleep study, have a blood next day to make sure at least it would direct you towards, as a biomarker, it can direct you toward a child that is more susceptible towards the neurocognitive deficit. Now, this is another topic that I would like to talk about, because you may say, okay, something in my throat happens. Because of that, something in my brain gets damaged. What is the connection between the two? How is that happening? Well, the connection is your blood vessel. Okay, now it's complicated. How my blood vessel is connected to my brain. Brain doesn't have blood vessel. So what's going on? So the endothelium, which is a single layer of cells lining inside your blood vessel, is the key. Imagine this is a child that comes to a sleep center, sleeps there. We measure the function of their blood vessel. We take a blood next day in the morning. Of course, usually they're not happy and smiling like that, but let's pretend. And we do a neurocognitive test, and then we run and give the blood to the scientists in the lab. Now, you would expect that every child with obstructive sleep apnea would have a very bad blood vessel function, because blood vessels should be affected. That is usually like that. Problem is, in the severe obstructive sleep apnea with obesity, there's a group of children that actually have neurocognitive dysfunction, and there's a group that are not. And there's a group that have severe OSA with obesity, and their blood vessel is completely normal. Now, how is that even possible? This basically means there is about 30-something% of children that are fat. They snore like crazy. They're choking every night, but there's nothing wrong with their blood vessel. How is that even possible? That's a whole puzzle. That brings us to another concept. Again, what goes to the brain and what doesn't go to the brain, and who takes what to the brain. That brought us, after many, many years of thinking and searching, to something that is called blood-brain barrier. Now, you remember from your probably biology and physiology that brain is the only organ in your body that has its own security system. The security system in the brain is actually a network of blood vessels that allows for the entry of certain nutrients and essentials to the brain cells and blocks the other stuff. So it's completely different than other things. So it's one layer of cells that allows for things to pass and some things not to pass. It's very selective, and it's called blood-brain barrier. That barrier is very, very tight. It's like a tight junction. It doesn't allow for anything that it doesn't want to pass. It's almost like that big wall in the Game of Thrones that Jon Snow said nothing will ever cross the wall. As all of us know, he knew nothing. Now, jokes aside, this is what's happening. Obstructive sleep apnea causes inflammation and oxidative stress. Something, which we're going to talk about, takes the insult through the wall being the blood-brain barrier, disrupts or breaks or somehow goes through the tight junction of the blood-brain barrier of the brain and causes our brain to malfunction or make our cognition lesser or dysfunction. And that's something, my friends, was discovered about 10 years ago, being something called exosome. Now, exosomes were discovered about 10 years ago. They are nanoparticles. They're extremely small. And they are almost like mailman or postman, that a cell wants to send another cell a message. They put the message or text in a little envelope or something, and they say, hey, exosome, take this to my friend, from secreting cell to another cell, and this is extracellular messaging. So exosome is basically maybe little car, or it's like what we call in Iran, peik, peik motori. It takes your message from one cell to another. So exosomes are those. They just take it from here and take it there, back and forth. So the exosome takes that message from here, from the vessel that is hurt, all the way to blood-brain barrier, passes through that, goes to your brain and say, hey, the obstructive sleep apnea says, start acting stupid. Now, how do I know? Because this is very simplistic, but I want to put it this way to make it easy. Let's say we do a sleep study, we do endothelial test to make sure that the blood vessel is affected. We got the blood, we got the exosomes out of the blood. We put the exosomes there and we check, make sure we mark that exosome so later on we can follow it. These are little technical issues that this by itself from here to here is almost like a year of work, but let's just forward. And then we put these exosomes, the messengers, injected into a poor mice that has no idea what's going on, and then measure their endothelial function. What I expect is that if the blood came from a person that has obstructive sleep apnea and endothelial dysfunction, that means that message says your brain should act really, really bad. Your brain should act like somebody who doesn't have much of an intelligence. Go act as stupid. Now you may ask, how do you get a mouse to act non-intelligent? Well, this is how we do that. We put a mouse into something called novel object recognition test. It's an empty box with two objects. One object is basically a solid object that mouse has seen before. One object is a new object. If a mouse is intelligent, he only goes and explores the object that he has never seen before. He leaves the object that he has seen before. If a mouse is a dumb mouse, in a way, or non-intelligent, to say it correctly, he will keep going to the thing that he has seen before because he doesn't remember it. It's like a child that has a toy, and once he plays with the toy once or twice, he doesn't want to play with it anymore. But if he doesn't remember it, every time he sees it, it's like, oh, an exciting red object, an exciting red new toy. Let me go check it out, a sniff, a sniff, a sniff. And then he goes back again and back again and back again because he doesn't remember it. He doesn't remember it. He doesn't remember it. So the computer on the right, the right side is actually the same measure, but computer measures the distance, the time that the mouse goes back and forth, back and forth, back and forth, and every time checks it out. A mouse that is intelligent will just go once and says, oh man, I've seen this before. No, thank you. That's how you know if the mouse is actually intelligent, has a neurocognitive function correctly or not. This is one of many different ways of measuring the cognitive function in rodents, for example. Another topic I wanted to bring to you is actually a very hot topic of sleep and cancer, which is quite recent and very hot topic these days. We know that sleep is quite related. If you sleep fewer hours, you're more likely to have a more aggressive breast cancer. If you have an irregular circadian rhythm, for example, people who have night shifts or people who are flight attendants, they keep going back and forth, they have more likely chance of having breast cancers. If somebody sleeps a lot, longer sleepers, especially in men, they're more likely to have colorectal cancers. And it's been shown that a sleep disruption, somebody who keeps getting asleep, repeated breaking of the sleep, somebody who gets calls and calls at night, may have an increased risk of prostate cancer. Now, what we have done in our group, almost 3 years of continuous experiments and many recent publications that we have, I'm just showing one of them, a large number of experiments, we have shown that when you expose an animal to the intermittent hypoxia, which is our way of creating a resemblance of obstructive sleep apnea in an animal, you make the cancer cell much more larger and much more aggressive. Not only the cancer cell becomes much more bigger, it also grows much more faster and goes deeper. We know that intermittent hypoxia and cancer are so related. As you can see, from 2012 until now, almost 8 years now, multiple groups have looked at multiple different types of cancers, and there are connections. Some of them are worked by our group and some of them from different laboratories. It is important that if you are a patient or you know a patient that has sleep apnea or irregular sleep, at least help them, if they have a cancer, to sleep better. Sleeping better helps their cancer treatment and improvement in their overall treatment. Now, the final thing that I would like to talk about is fresh off the oven. 2 weeks ago, we had a publication that made the news. This is about what you eat can affect your sleep. And this is about sleep and gut microbiome. Now, it's been known for almost a few years now that gut microbiome can change many different things, but nobody ever thought about gut microbiome having effect on your sleep. Now, this is a very simplistic slide just to show you the concept. Bunch of mouse were put into either obstructive sleep apnea model, which is intermittent hypoxia, or breathing normal air. We collected their fecal samples and feed the fecal samples back into the normal mouse. They're all identical mouse. Now, we didn't feed them, we actually injected them back. These received the sick, basically, fecal samples, microbiome from the sick mouse, and these received the microbiome from the healthy mouse. So their sleep was not changed, and the group that received the microbiome from the group that had obstructive sleep apnea actually started to be very sleepy and sleep more. Very, very revolutionary, meaning there are certain things in your body that changes. In your guts, if you can change what is in your microbiota of your guts, you may be able to improve your sleep apnea or your sleepiness. This is incredible finding. This is very revolutionary. And we are, as we speak, talking about new projects. We are thinking about use of certain ways that may open new doors for treatment without surgery, without having to give medication, in a very different way, instead of using the upper airway, actually going through the guts. This work was done by our very, very new fellow, Mohammed Badran, who is a very young fellow, just recently joined us, less than a year, Dr. Khalifa, and in our laboratory. And this was extremely well received. Over 4 million view has been over in the last week, and I really wanted to show it to you. Well, this wraps up my lecture for you, and I'm very honored and pleased that I was invited. Thank you for your attention. And I would like to acknowledge all the people that helped me with help us in our laboratory, and also the two people that actually passed away, the Professor Maylus Alonso Alvarez and Professor Joaquin Teran Santos. Both of them passed away in the last year, and this has been a major disaster, but they helped us with the project with cancer. And thank you for your attention.
Thank you very much, Dr. Khairandish, and I should apologize for the inconveniences with the internet connection. It was not secure, so we have some problems with that. So sorry about that.
It's okay, I understand.
And I should thank you for answering questions rapidly in the chat section. Thank you very much. So if I may, I would like to ask Professor Fanus. Welcome, sir. Thank you very much for participating in this session. I would like to ask him to continue with his very valuable presentation. You can ask your questions in the chat section from dear Dr. Khairandish. She will be with us during the remainder of the session.
Just a minute before Professor Fons gets started, I wanted to ask one question from Professor Khairandish. In fact, it is out of your presentation, but who is in your center in charge of sleep apnea, a cardiologist or a pulmonologist?
Pulmonary hypertension.
Yeah, depends. Each center we have different, in each university there had been different groups. So the way it works in USA, I apologize, Professor Fanus, if you don't mind, I'm sorry. I will just be very, very quick. In each center is different. At this university, the pulmonary group is the one in pediatric, and in the adult center, it's the neurology. But there is only one umbrella for the fellowship that is always taking over. So pediatric and adult has to be joint. So we cannot have separate ones. So although we are pediatric specialized, but when you go through the fellowship, it's only one program. So we are trained in both adult and pediatric, but later on you can decide which one to practice.
Thank you for your answer. Now it's time to Professor Fanus. Professor Fanus, we have followed your speech yesterday, and it was more than fascinating. All of us were amazed here, and we are interested in it, and we are willing to listen to your lecture. Thank you.
Thank you very much. Can you hear me? Can you see my screen?
Yes, Professor, go on. Thank you.
Thank you for your comment, dear friends. Again, thank you very much for inviting me and for giving me the possibility to give a second lecture. So my job today will be to talk to you about gut and lung microbiota in acute respiratory diseases. And I thank also the previous speaker. I thank very much because she paved the ways, as we say, with the last slides to my presentation. And this is the agenda of my presentation. And the subtitle of my talk could be the dark matter, or if you prefer the unknown. And 4 topics, but the backbone of my talk will be acute respiratory disease and coronavirus and gut-lung axis and microbiota. And the story starts from this paper that I published in the journal of which I'm editor-in-chief, which is also the official journal of the Union of Middle Eastern and Mediterranean Pediatric Society and other international societies. And in a few months, we had 12 citations. And another inspiration could be this paper, which is one of the last I published on PubMed, the dark matter of microbiome, the mother-infant pair virome. Because when we talk about the microbiome, we normally think to bacteria, but there are also the virus, the bacteriophagi, the fungi, and helminths, and protozoa, and so it's a dark matter, really dark matter. And what about coronavirus in newborn children? We are drawing in COVID-19 papers. In fact, as you can see in PubMed, about 25 papers are published per hour. So it's very difficult for everybody to follow all this literature. And this is our invisible and terrible enemy. And this is the attack to the lung cells of the virus particle. We studied in a deep way this attack, and what is important to tell you by me is that the localization of ISA2 receptors is diffused in all the organs, not only in the lung. Today it's possible to, with immunochemistry methods, to capture the real localization of, for example, in the intestine. But I want to share with you these slides because very few people knows that in the intestine the number of ACE2 receptor is 4-fold the number that is present in the lung. So this is interesting. In children, we have less receptors in the tissue, as less affinity for the virus. This is one of the reasons because the children are less affected. And let's see in the last part of my talk. And again, we studied the relationship between pregnancy and coronavirus, what we know, but also what we don't know. For example, vertical transmission is still controversial. And another important topic to me is the offspring's long-term outcomes, because nobody knows what happens even in asymptomatic children later in life with the so-called and well-known process of the fetal programming or perinatal programming or developmental origins of health and disease. So we know the distribution, the different ages, and the numbers, as we say, as we know, matter. And the age distribution in hospitalized children, this is a paper from the United States, is higher in the first years of life. And also the number in intensive care unit admissions is higher in the first year of life. Most of these children present important concomitant diseases. And this is the panel of the symptoms in children with COVID-19 disease. But you know that this topic is interesting because the syndrome of coronavirus could be present with diarrhea without fever and cough. And this is a problem for the containment of the disease. And if we look at the multisystem inflammatory syndrome in children, we can see that diarrhea and vomit are present in a very high percentage of cases. So the presence of diarrhea and vomit of gastrointestinal symptoms is very important for the physicians. This is a paper that is not just published, it's on preprint, it's a preprint, but in a very high number of children during the lockdown period in Italy, we are initiating another, unfortunately, lockdown. And we were able to demonstrate that the presence of diarrhea and fatigue, unexpected and unexplainable fatigue, in absence of sore throat and ERH and abnormal skin size, is a very strong predictive symptom for a diagnosis of COVID-19 disease. Even without the execution of the analysis of molecular analysis. And in particular, you can see that fatigue and nausea, vomiting, and diarrhea are very important in absence of sore throat, ear ache. So we studied also other organs, for example, the heart or the kidney, which is not a figurant, it's a protagonist to me. But let's move to the microbiota. This we know from very interesting paper that it is very important, the maternal microbiota and the infant microbiota, and these are related also to the most important epigenetic factor, which is the nutrition. And in moving from the first trimester to the third trimester of pregnancy, there is an alteration of microbiota, which is similar to that of diabetic and obese mother. There are microbes that are great extractors of energy. This is functional to the acquisition for the newborn at birth and for the placenta of healthy bacteria for the newborn. We know from elegant studies with germ-free animals. And also we know from this paper and other, the strict relationship between the virome and the microbiome, because if we take the pregnant women at the third trimester of pregnancy and obese non-pregnant women, they have a particular vulnerability to influenza virus. And if we perform vaccination in these women, they are able to produce a very few number of antibodies and less efficient antibodies. But the strange thing, if we perform a transplant of the microbiota in animals, of their microbiota, we are able to transmit these two properties. So what is the key message for you is that the microbiome and the virome and the third brain, which is the immune system. The first brain is the first brain, the second brain is the gut, the third brain is the immune system, connected together to determine something that we don't know, that like the previous speaker very efficaciously talked. And we have different epigenetic factors that could be a relevant factor for the dysbiosis. I wrote a whole paper on the pioneers back that are responsible for a good health or a bad health. And lactobacilli are the pioneers backs. And please note also the birth weight that is related to the placental microbiome, to the placental lactobacilli. And please see in the first days of life how the increase of bifidobacteria and lactobacilli is important in the colonization of the human newborn gut. Lactobacilli are the bags that kiss the mucosa because they are able to stay just in front of the mucosa. All the other bacteria stay in the mucus. And the bifidobacteria represent 1/2 of the neonatal microbiome, and both are all friends of our species from 200,000 years. They are represented defense for our organism. And we as mankind had evolution with the co-evolution. Each evolution is a co-evolution, and we had a co-evolution with this bacteria. And one of the problems today is the presence of bifidobacterial dysbiosis, preterm prematurity, cesarean section, newborn infants fed with the formula, antibiotic treatment. And I showed this slide also yesterday, and we are studying the dysbiosis in necrotizing enterocolitis. And please see the microbiome. See only the colors because it's impossible to make a comment on these slides in a quick way. And it is very different from controls and necrotizing enterocolitis. And we have very different species of bacteria colonizing the gut. Something which happens in this very vulnerable period of life could be related to important disease later in life. Just remind to obesity and also to autoinspector disorders. And now let's move to the backbone of my presentation. And I would like to suggest this fantastic review with fantastic panels to understand the gut microbiota. I have no time to describe the physiology and the physiopathology of the gut microbiota. You can find excellent papers in the literature, and I also remind my book that has been translated in English and in other languages, in Greek, in Romanian now. And we know what happens at the level of the cells, and we know that also the lung has a microbiota with normally 6 bacteria, and the difference is that in the gut we have one human cell each 10 bacteria, but in the lung we have one bacterium each 100 cells. So the difference in the quantity of cells is 1,000. And we know that in respiratory disease, there is the gut-lung axis. We know very well that now the name of the bacteria that are present during normal health or bad health. And we know that in all the viral infections, children and also adults present diarrhea, vomiting, abdominal pain, and also in animals it's the same. So there is an involvement on the intestine during viral disease, you know, like me, this detail. And this is true for some important disease like influenza A virus infections, which is related to dysbiosis, and the consequence of the infections is also dysbiosis. So there are some vicious circles on this argument. Again, we have other papers, and the impact of the dysbiosis is related to the caloric restriction in experimental animals. But the most important thing to me to share with you, and I think it's a cutting edge, this topic, is the relationship between the gut microbiota and COVID-19 disease. And now we know from very recent papers that there are alterations in the gut microbiota of patients with coronavirus infection at the moment of the hospitalization. In particular, you can see that there are a reduction of some good bacteria like Faecalibacterium prausnitzii and Roseburia, and there is an increase of bad boys bacteria, as I call them, like Clostridia, on other bad boys like Coprobacillus. And this is very important because you know that Clostridia are related in the organism to preeclampsia in the pregnant woman, to necrotizing enterocolitis in the newborn, to Crohn's disease, rectocolitis ulcerosa disease, autism spectrum disorder, and even stroke in the cardiac stroke in the adult patients. So this slide is very important to me because what happens normally, there is a bidirectional relationship between the gut and the lung, and normally the gut produces, you know, the short chain fatty acid, and the butyric acid is very important, and reaches the lung and contributes to the equilibrium of the lung, not only by the biochemical cytokine point of view, but also of the microbiota. In each respiratory distress syndrome, in each viral infection, there is the phenomenon which is called more of the gut in the lung. So the bacteria of the gut moves towards the lung and colonize it, and you know there are a lot of bacteria that normally are not present because normally there are bacteria derived from the oral cavity. And not only it's a problem of quantity, but it's a problem also of quality. So I wrote this instant review, and then this observation was confirmed by other researchers. This is a very elegant panel. I have no time to discuss that, but I would like to share with you with a more detail these slides. This is an adult patients who who in intensive care unit who are intubated have Enterobacteriaceae in their microbiota of the lung. Those who are not intubated don't have Enterobacteriaceae. That's incredible. It's a dramatic difference. And those who are intubated present and will die, present a very high concentration of Lacnospiraceae. So the importance of the microbiota is extremely high. And today there are very elegant studies with the omics technology like metabolomics and microbiomics, and I told you yesterday, and it is possible to clearly discriminate healthy microbiome, a microbiome of community-acquired pneumonia, microbiome of COVID-19 disease. And I was very surprised when I read this paper related to the outcome of children with severe coronavirus disease infection and admitted in the neonatal intensive care unit of Canada and United States, because only 17% were treated with antibiotics and were treated with macrolides. But what happens is that these children have like the adults, have the phenomenon of more gut into the lung. So it is not possible to leave these children without antibiotic, and only 17% were treated with azithromycin, which is not efficacious against Enterobacteriaceae and all the bad boys coming from the intestine. We know from some studies that also for an unknown reason, the antibiotic-treated children has a decreased viral replication. Don't ask me why, because nobody knows on the surface of the earth. So we published some papers about that, microbiota, and which came first, the chicken or the egg in coronavirus. And maybe that the protection due to the magic of human milk could be related not only to lactoferrin, not only to stem cells, but also to the microbiome, which is related, as I showed before, lactobacilli and bifidobacteria. Now you can understand why I talk about the newborn, and now I'm talking about the child, the adolescent, and the adult. And I want to show you this slide is one of the 6 metabolomic studies that have been performed. It is possible without any overlapping to understand the healthy patient and patient with COVID disease and the different grading of the severity of the disease related to high level of interleukin-6. Because when you have the phenomenon of more gut into the lung, the interleukin-17 is substituted by interleukin-6. And so what happens is the cytokine storm, as you know. And it is possible to go into depth of the information and to understand all the pathways, all the metabolites that are involved in this issue. And you can see very elegant studies. So you can capture the complexity of what happens in our organisms with creatinine and transaminase. You need to have a tremendous complicated technology like the omics. These are other papers so complicated that are difficult to read, and many physicians don't read because they are too complicated. It's possible also to pharma metabolomics to anticipate the effect of the drugs. This way with an urine sample or a blood sample. So I think that's a very important topic. And as I suggested to you yesterday, metabolomics, microbiomics, and machine learning, the 3M, could be the future in research in medicine. And I can anticipate to you that we could have a picture like this, a patient, they are the same clinical picture with mild symptoms and signs, but this patient will go to intensive care unit and will die. This patient will be discharged, but he will or she will have a pulmonary fibrosis, and this will be really mild symptomatic without any problem later in life. Why I am showing you this slide? Because we can capture the extraordinary strong inter-individual variability that I discussed with you yesterday, and very important study. This is another study on microbiomics. Look at this detail. It is possible to correlate in a fantastic way all the metabolites that are related to the microbes, and also to interconnect microbes and metabolites and having a deep of information that could be useful, because what we can do today is we can change our microbiota with prebiotics, probiotics, symbiotics, and postbiotics, and also with other epigenetic factor in adolescents and children, exercise, and what is more important to me, nutrition, individualized nutrition. I will not talk about the fecal transplant. If you want, we can discuss in later. So there are potential application of probiotics, prebiotics for the prevention treatment of COVID-19. And it's not a surprise, because the gut and the respiratory tract share the same embryonic origin. And also probiotics and prebiotics could be applied to prevent or treat COVID-19 waiting for the vaccine. And there are papers in the literature like this. It's possible to restore the gut microbiota to have an improvement of the lung microbiota of the lung respiratory disease. So it's really possible in experimental animal to perform all these things and have an improved respiratory health. But it's very interesting, because the beneficial microbes are lactobacilli, 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 and given intranasally and orally. So they are able to modify immunity, the immune system, and to improve our health. And a lot of papers, as you can see, I show only part of these papers. And what happens is that in humans, we can suggest lactobacilli, in particular lactobacillus bacteria and bifidobacteria, but also the two stars of the intestine later who colonize the infant and the child after 1 year and a half. So, is a healthy microbiome responsible for lower mortality? Please look what is suggested by papers of the literature, like Bacillus subtilis, Lactobacilli gasseri, Lactobacillus rhamnosus, and because some of these bacteria are able to increase secretory IgA in a very fast way. Please look after 2 days. So it is possible also to use this lactobacilli to prevent other respiratory infectious disease, like for RSV. And finally, I want to show that it's possible to perform fantastic study with the so-called chips, the stem cell-based lung on chips. So it is possible. This is the gut, and this is an example of personalized medicine application in research. And we can have also excellent information by the use of human bronchial organoids, also human cells. So I'm finishing. Our particular personal war against the virus is we are looking to all metabolomics of the urine of infant of mothers of with positive to the infection, and newborns and infant positive to infection. With all my fellows, we published a lot of papers, and within the end of the year will be about 17 papers published in PubMed. And these are my collaborator and all the names of the fellows. And Professor Fa, studying the microbiome, my fantastic group of metabolomics. So something to remember, the 3 M's, microbiomics, metabolomics, machine learning, and artificial intelligence. The president of the Italian Society of Pediatrics, 11,000 pediatricians in Italy, wrote that before coronavirus and after the coronavirus, nothing will be like before. So I think we must approach, and I'm finishing with my last slide, all this topic and all the topic of science with the wisdom of humility. the only wisdom we can hope to acquire is the wisdom of humility. Humility is endless. And I thank you very much for your attention.
Thank you, Professor Fanos. We were more than fascinated by your nice, great lecture, and I was taking notes myself indeed. I encourage audiences to use the chat section to ask their questions, and we will ask the lecturers each questions at the end of their sessions. And now, next we will have Professor Rabelli to tell us about classification criteria for macrophage activating syndrome complicating systemic juvenile idiopathic arthritis. Professor Rabelli, hi, thanks for joining us today. Yes, I have made it.
Thank you very much. I thought there was another lecture before my my lecture, so but anyway.
Yes, Professor, the program has changed just a little, but if you are agree, we will have your
yes, no
lecture.
problem. Yeah, no problem. I was not
very
yet
much.
ready, but we'll be ready shortly.
Can I have a question while Dr. Ravelli is getting ready? Is it okay if I have
Sure.
That gives a
Yes.
bit of time to Professor Ravelli as well. Is that okay, Professor Ravelli?
Could be? Can you?
Can I have a few minutes before you start?
Yeah, no problem. Of course, no problem.
I ask a question from Professor Fanos.
Of course, no problem.
Is Professor Fanos available?
Here I am.
Easy.
You.
Okay. Thank you. Wonderful. What a wonderful.
Ciao, Vasilios.
Thank you so much.
Carissimo, ciao. We were talking Italian, speaking Italian.
We can speak Italian, so I guess few of you
we learn also Italian.
Understand. Yeah.
Professor Fanos, what a wonderful lecture. It was amazing. It was amazing. So as you just mentioned, it's the 3 M's. So I have been fascinated. It was amazing. Thank you for this beautiful lecture. I'm sorry that I missed the yesterday lecture, but I will, thank God I can go back and look at the recorded one. Forgive my ignorance, but just as a person that doesn't really know much about the microbiota yet, and I'm not an expert in that field, out of curiosity, do you think that the relationship that we are finding on the fecal injection back to the fecal feeding back to the animals that we have experienced so far, having the obstructive sleep apnea not being an infection but being an inflammatory process, it of course is same concept in a way. If you were to use a benign probiotic, what would be your just throw in the hat maybe choice of probiotic to maybe reverse? Yes,
thank you. I also appreciated your talk very much, and you paved the way to me, and I completely agree that this is a completely a new topic. Yesterday I told that I'm studying metabolomics for 14 years, and I moved to microbiomics necessarily after 1-2 years to study also microbiome because metabolomics is considered the Rosetta Stone of microbiomics. So what you are talking about is very interesting. If you look to germ-free animals, they don't have inflammatory and autoimmune disease. So this is a key message. They don't have asthma, they don't have eczema, they don't have a lot of disease, arthritis, rheumatoids, and so on. The last question, which is my preference, I told you that the old friends of the humans, lactobacilli, that are donated is a gift that the mother gives with the vaginal secretions during vaginal delivery, and the bifidobacteria that are given mainly by the microbiome of the milk. So these two, which lactobacilli, those who are more studied in humans and in children, Reuteri, Lactobacillus gauteri, and Lactobacillus GG rhamnosus. This could be my, but in coronavirus, all the literature is Gasseri, Lactobacillus gasseri.
Gasseri.
But it's more difficult to find in the market. So
But,
the other two that I suggested to you have more than together more than 500 papers published.
Wow.
So it's important because there is a specificity of the type of the microbe. So it's not that one fits all. There is specificity of the bacteria.
Another ignorant question, so Dr. Ravelli can have more time. Again, I'm showing my ignorance. How much time it would take? Maybe let's say we just designed this simple experiment. Somebody has some disease. We want to treat it. Give it a, let's say one of these bifidobacteria or whatever, lactobacilli. Okay, how long should I give it?
Yes,
how much time to change
yes, it's a very generic question. So I say it depends on the disease. What I can say is that a very important thing today is the socio-microbiology of bacteria, or it was published in Italian, a book, Anthropology of the Bacteria. If we look at the life on the earth, all the period of life in the earth, one day, we are living only in the last 5 seconds compared to bacteria. So I don't know if we are imitating bacteria or it's the opposite thing. And normally, it is important to modify the whole microbiome. We are used to the Koch postulate, one bacterium, one disease. No, in this case is the socio-microbiology, the importance of the different species in the consortium. So I think that normally you can have to change a microbiome, I think 1 year.
1 year.
To have, yes, but to have positive and beneficial effects, I think that 1, 2, 3 months you can observe
see an actual change,
yes,
significant
yes,
change.
yes. And what happens is that if you give bacteria, the bacteria produce metabolites in relation with the food, and the metabolites are the words when the cells have a dialogue with the bacteria, they use the words of the metabolites. So they are the secret language of the bacteria and the cells, and the axis of our organism.
Maybe the exosomes? Maybe the exosomes? Maybe, but so you would think that maybe 4 weeks, 8 weeks, maybe 12 weeks maximum, we would be able to see something significant change.
You can find modifications that are, of course, detectable with sophisticated analysis like the omics. So you can see the modification of a well-being, and also on the opposite side, if you have a pathology, even important, but without clinical signs, you can capture very early diagnosis of what's happening in the organism. And if you are used to know this secret language, you can understand everything. Yesterday, I showed some slides on personalized medicine, on the modification of in single individuals with autistic spectrum disorders, Pandas disease, or other fibromyalgia, with very important clinical results. It's not experiments on mouse.
Yes.
Clinical result in humans.
Yeah.
This is my opinion.
Absolutely. Thank you very much. I appreciate your thorough answer. It was wonderful.
I did a good job for Professor Ravelli. I hope so.
Oh yeah, we did our best.
You did. You definitely did. You definitely did.
Thank you.
Thank you.
So you thought of some diseases that I'm dealing with, such as fibromyalgia, arthritis, and so on and so forth. So we have many points of contacts.
Yes, Professor Ravelli, we are all ears with you. Thank you for your patience and your cooperation.
So what should I do? Should I start my lecture?
Yes, please.
So let me share the screen. Okay.
Yes.
Okay. Do you see my slides?
Yes, it is
very nice. Yes, sir.
Okay. So thank you very much first for the invitation. It's a great pleasure to be with you tonight, even though unfortunately not in person. Hopefully there will be another occasion in the future. I've been to Tehran once a few years ago. Hope to come back one day. So let me first introduce myself. I'm Angelo Ravelli. I'm the head of the rheumatology unit at the Gazzini Institute of Genoa, Italy. I'm a pediatric rheumatologist, and I'm actually also the president of the European Pediatric Rheumatology Society. So I'm very pleased that you have asked me to present the multinational efforts project that has led to develop what are now called the 2016 classification criteria for macrophage activation syndrome complicating systemic juvenile idiopathic arthritis. But let me start reminding you why classification criteria, we can't nowadays call any criteria for a disease as diagnostic for medical legal reasons, why criteria for MAS are important. So as you all know, MAS is a serious complication of pediatric rheumatic diseases, particularly of systemic juvenile idiopathic arthritis, which can be life-threatening. And early diagnosis and the prompt institution of a correct, appropriate treatment are critical and can be life-saving for the patients. However, everybody knows that because there are no distinguishing or pathognomonic features, and MAS can be heterogeneous in its clinical pictures, early, timely diagnosis can be difficult. And furthermore, the features of the clinical and laboratory features of MAS can be mimicked by some clinical conditions, such as a flare, a simple flare of the underlying systemic JIA, and infectious complications, for instance, leishmania or EBV-related HLH may mimic the features of macrophage activation syndrome, and also some medication side effects, particularly when there is liver failure, may also be difficult to discriminate from MAS. But on top of that, there are reports such as this one by a group of US colleagues and friends, I should say, which has suggested that MAS may be indeed much more common than usually thought in the context of active systemic JIA. And nowadays, it is widely realized that overt, full-blown MAS occurs in 8 to 10% of children with systemic JIA, but another 20, 30, or perhaps even 40% of children with this disease may display subclinical signs of MAS, which, if not recognized and treated promptly, may progress towards a full-blown and potentially life-threatening syndrome. So what are the aims of classification criteria, the general aims? Of course, they help standardize the classification of the syndrome for research purposes or publication. So make sure that patients included in studies or in trials really have MAS and not something else, because the criteria should unify the classification. They may assist in the evaluation of different therapeutic approaches because they make more rational the conduction of trials. And they also may foster interaction between specialists in different fields, because MAS and hemophagocytic syndrome not only involve the interest of rheumatologists, but also of immunologists, infectious disease specialists, intensivists, and cardiologists and others. So this having shared criteria enable these specialists to talk the same language. So they talk about the same condition, not to something that is called in the different way by each specialist. And last but not least, they may also, the well-established criteria may help the caring physician, the treating physician, to make an early diagnosis of the disease. So our group has been long interested in the creation of criteria for MAS in systemic GIA, and these are the time-honored preliminary diagnostic guidelines for this syndrome, which were published in the Journal of Pediatrics already 15 years ago. I have no time to go through these criteria. They include 4 laboratory criteria, 3 clinical criteria, and these criteria, of course, are nowadays old. They are a bit outdated. They do not incorporate the most recent development, but they have played a very important role because they have very much helped to disseminate the awareness for this syndrome, which was not enough known by physicians out of the context of hematologists and rheumatologists. And I think they have helped to save a number of children's lives. Anyway, as I said, they are now a bit, they have got a bit old. They were based on retrospective data, do not incorporate some laboratory measurements that are nowadays we know that are very important, primarily ferritin, because at that time the role of these biomarkers was not yet recognized. And last but not least, they have not been formally validated, have never been formally validated. So someone particularly in the hematology field has suggested to use the HLH 2004 diagnostic guidelines to diagnose MAS. As you know, these guidelines were developed for the genetic forms of hemophagocytic syndrome, which are different in some aspects, although clinically very similar to MAS, but these criteria are not adequate to detect early a complication which occurs in the context of a highly inflammatory disease such as systemic GIA. For instance, if we wait that platelet count drops below 100,000 or that the fibrinogen level decreases below 150 milligram DL, it might be too late for our patient. In an inflammatory disease such as systemic GIA, it is more important to value the relative drop from a high value, for instance, of platelets and of fibrinogen, rather than to wait for the level of this laboratory test to decrease below a certain threshold. Because we know, for instance, that in a patient with active systemic GIA, if platelets decrease from 600,000 to 350 in 48 hours, so 350 is still normal, but a decrease of 250,000 is highly significant. And the same applies to fibrinogen. Another problem with this criteria is that ferritin level 500 is too low to discriminate MAS from active systemic GIA, because we know that many children with active systemic joint idiopathic arthritis have a background ferritin far above 500, 1,000, 1,500. Is not uncommon to see in the context of that active systemic GIA without evidence of MAS. But when MAS starts, ferritin level increased markedly to 15,000, 30,000, and even more. So the relative increase in ferritin, again, is much more important than the absolute threshold. So, but since we like to demonstrate our, let's say, our hypothesis in an evidence-based way, we compared the diagnostic performance of the HLA 2004 guidelines in 2 different formats. The more sophisticated lab immunological parameters were not available, and also the bone marrow aspirate was not made in many patients with MAS or systemic GIA. We compared anyway these guidelines with the preliminary, the original MAS guidelines, and also with 3 versions of the original preliminary MAS guidelines with the addition of ferritin at 3 different thresholds. As you see, in the end, the best balance between sensitivity and specificity and the higher kappa value was still provided by the preliminary MAS guidelines. So the HLH criteria were extremely specific, which means that if a patient met this criteria, he or she had MAS, no doubt, but this criteria picked up only 1/3 of MAS cases. So this means that they missed in the more complete format as many as 2/3 of diagnosis of MAS, which is an imitation. Unexpectedly, the addition of ferritin did not increase the performance of the criteria, and this is probably due to the fact that ferritin level is extremely variable across diverse patients with MAS, and so it's very difficult to set a threshold that fits to all patients. Anyway, because none of the old criteria was entirely satisfactory, a few years ago, we decided to start a multinational effort which was aimed to develop new, well-established classification criteria for MAS complication systemic GIA, and I personally led this project, which was based on 3 subsequent steps. First of all, we made a Delphi survey among international pediatric rheumatologists, which was aimed to select the clinical laboratory features that were felt by these experts as potentially more important for inclusion in the criteria. Then we launched a large-scale data collection, which was aimed to collect real patient data from MAS and from 2 potentially confusable conditions. That is, with 2 conditions that are potentially can be potentially confused with MAS in the clinical setting. And these conditions were instances of active systemic GIA without evidence of MAS and instances of acute febrile infection requiring hospitalization. So we, through statistical analysis, we aim to identify those clinical laboratory or histopathological features that were best suited to distinguish, to discriminate MAS from the 2 potentially confusable conditions. And so once the data collection was completed, the statistical analysis were made, we ended up the project with a consensus conference, which gathered a group of selected experts, which were, let's say, were committed to develop the final criteria based on the results of statistical analysis, on the analysis of real patient data, and of course, on their personal opinions and expertise. So the Delphi survey, I won't go present you these data for sake of time and because they have been published in the Journal of Rheumatology. If you are interested, you can take a look at this paper. If you do not have access to the paper, just drop me an email. I would be more than happy to send you the PDF of the study. So the data collection was involved, you see, 95 investigators from 33 countries all over the world, and we collected the database was handled at my hospital, at the Gazzini Institute, 1,111 patients with MAS or with one of the 2 confusable conditions that you see here, the sample distribution. And at this time, the project became multidisciplinary because beside pediatric rheumatologists, we were joined by a group of pediatric, also hematologists belonging to the Histiocyte Society. And then the consensus conference, which was preceded by a number of pre-meeting web consensus evaluations. So we asked the experts that were selected to make a number of evaluations. We show you some details in a while. And also we ran a number of statistical analysis to end up with let's say, an adequate bunch of data, which should have enabled the expert at the consensus conference to try to reach agreement on the final classification criteria. So this is the expert panel was composed of 27 specialists, 19 of them were rheumatologists and 8 hematologists. So what we first asked to these experts was to examine real patients which could have MAS or one of the 2 confusable conditions. We submit the patient profiles of these patients mixed without, of course, telling them the diagnosis. And then we ask them to classify each of these patients as having MAS, in their opinion, positive for MAS or not having MAS. Patients for which there was no consensus, that is, for whom less than 80% of experts did not reach consensus or diagnosis of MAS or no MAS, were discarded. And these evaluations have been simply based on clinical and laboratory data at the onset of the disease, because we were interested in establishing criteria that could help to diagnose and recognize and classify, of course, MAS at its onset. So for this exercise, we selected a total of 428 patients profiles from the entire patient samples, 161 at MAS, 140 systemic GA, active systemic GA without evidence of MAS, and 127 systemic infections. These diagnoses were made by the original treating physicians who had seen the patient in the clinical setting. So were clinical diagnosis by the physician who saw these patients. So these participants were asked to work extremely hard, not that hard as in these pictures, but quite hard, because we ran three subsequent rounds of evaluations, and this is an example of the profile for each patient that was submitted to these experts. So we listed the main clinical features of MAS, and then wrote whether the patient had or did not have this feature. For instance, this patient had fever, lymphadenopathy, hematomegaly, but did not have splenomegaly, hemorrhagic manifestation, jaundice, and so on and so forth. And also we listed the laboratory features at onset with their normal range. You see, for instance, this patient had anemia, leukopenia, neutropenia, loose-collated platelets, transaminases elevated, fibrinogen dropped, and ferritin 10,000. So in the end, we asked the experts, so after having reviewed these clinical features and laboratory features, do you feel that this patient have MAS, yes or no? I guess you agree that a patient with these features clearly has MAS. So these experts made this evaluation for all 428 patient profile for 3 times. So very hard work. So in the end, we were successful because we had more than 90% of the profiles for which consensus was reached, that is, for which more than 80% of experts agreed that they had MAS or they did not have MAS. Interestingly enough, 47 patients which were classified as MAS by the treating physician was not confirmed with this diagnosis by the experts. A few patients with systemic GA or infection were classified, however, as MAS, but very few. So then we had these 39 profiles, which were the gold standard for the study. And then on these profiles, we tested a large number of classification criteria derived from the literature, the one that I've shown you before, preliminary guidelines, modified guidelines, HLH 2004 criteria. And then we derived a large number of theoretical criteria, which were generated from study data using 2 different statistical approaches, combination of criteria approach, and I won't go through the details for sake of time, and by assigning a weight to each clinical laboratory variable through a multivariable regression analysis by constructing MAS score. So we selected, we tested almost 1,000 potential definitions. We selected 45 based on their statistical performance. We were quite demanding to retain a set of criteria. We required a kappa value above 0.4. So you look at the sensitivity, specificity, are under the curve should have been above 0.9. We made an exception for the historical definitions because due to their historical meaning and importance were retained even though their performance were below the established threshold. So we ended up this project by holding a consensus conference in Genoa in 2014 in this beautiful villa which belonged to our hospital. Unfortunately, it has been now sold, but anyway, this was a very good venue. And these are the experts which participated in the consensus cover. They come from all over the world. They were smiling, Italian food, Italian weather, Italian wine that was close to the side, so the sea. So this helped very much. Of course, they forgave us for such a hard work, but they work again very much for 2 days. The goal was to examine these 45 definitions which were left and to examine each of them and to rank them from 1 to 5. 1 the 5 to the best and 1 to the less, let's say, appreciated. So these are the tables. One table was moderated by Nicola Ruperto, and another table by Hermine Brunner, Nicola Ruperto from Genoa, Hermine Brunner from Cincinnati. So we tested the 45 definition. We made a number of subsequent rounds of assessments, and in the end, we were lucky because a consensus was reached on the final definition, which was retained in the final criteria and became the final 2016 MAS classification criteria. So based on this criteria, a patient which should be febrile, fever is mandatory, which known or even suspected, suspicion is enough, systemic GIA is classified as having MAS if the patient has ferritin above 684 nanogram per liter. This is another mandatory criteria, plus at least 2 of the following 4 abnormalities. You see platelet count less than 181, elevated transaminases, elevated triglycerides, and fibrinogen 306 less than 350. So it is not surprising for what I said before that the threshold level for platelets and fibrinogen is within the normal limit. But again, for a highly inflammatory disease like a systemic GIA, this level is low. And as I said once more, it is more important to value the change over time rather than the achievement of a particular threshold value. So these criteria have been endorsed by the main international rheumatology networks, by the EULAR in Europe, and by the American College of Rheumatology in North America. So they have become the official criteria for both these organizations. I am finished. I thank you very much for your attention.
Thank you very much, Professor Ravali. We really did enjoy your presentation, and we learned a lot. In fact, there are 2 questions in the chat box. If you let me ask you, and one of them is that, let me see, please.
Thank you very much, Professor Ravali, for your very beautiful presentation. On behalf of all our executive and also scientific committee, I should thank you, especially Dr. Ziai, send you some message and thank you in person.
Thank you so much.
Professor, one of these questions is that, do you agree with the hypothesis that MISC is a new presentation or similar syndrome of macrophage activating syndrome?
So MIC, you mean the Kawasaki-like condition associated with SARS-CoV-2?
Yes, yes.
This is a very interesting question. So I think that the discussion should be more if MIC is similar to Kawasaki disease or is a kind of variant, more aggressive, let's say deformed by the virus. But I think that Professor Singh would be more suited than me to answer this question. But I've been very much involved in this discussion internationally, and I will give a talk on Sunday night at the American College of Rheumatology on this issue. Regarding, I think that MAS can occur in Kawasaki disease, we know. It's probably more common than usually thought. MAS has been seen in MIS-C. Many of these patients had elevated ferritin and other features of MAS. But I think that kind of toxic shock syndrome with myocarditis and shock, which also can complicate Kawasaki syndrome, is more common than overt MAS in patients with MIS-C. What we know is that adult patients with lung disease develop, some of them, those with with a lethal and more severe course, develop a cytokine storm syndrome, which is probably within the spectrum of MAS within the lung. This is what makes their disease course so complicated and risky.
Thank you, Professor Ravadi, for your nice response. Another question is that, what's your opinion about the probable primary immune deficiency in children who experience MAS in systematic JIA?
primary immune deficiency is a different condition. So children with system AGA usually do not have immune deficiency; they are immune competent. So it's I think I can't answer this question. So immune deficiency, I think, is rarely complicated by MAS, because MAS is a hyperinflammatory condition. So is due to an uncontrolled, dysregulated, excessive immune response, which leads to an overwhelming, massive hypersecretion of pro-inflammatory cytokines such as IL-6, interferon gamma, and IL-1, and so and others, IL-18, and this is the reason why MAS occurs. So this is a different scenario as compared to immune deficiencies.
Thank you very much. Another question there is, how can we differentiate between MAS due to JIA and other conditions such as infections or other rheumatologic disorders by laboratory indexes?
So how can we differentiate MAS system AGA from other forms of MAS? So it's usually when MAS occurs after the start of systemic JA, so we already know that the patient has systemic JA, so it is not difficult to diagnose MAS. However, we know that in around 1/4 of patients, MAS can occur at the onset of systemic JA, and even when arthritis is not yet present. So in that setting, it's difficult to distinguish MAS from virus-associated HLH, or even from another MAS due to other kind of infection. For instance, I don't know if in Iran you have this infection, Leishmania visceralis. Leishmaniosis is endemic in many parts of Italy. So I have seen not in systemic JA, but for instance in lupus, I have seen at least a couple of cases of MAS, because we know that MAS can occur in lupus also. Is a bit different from that of that is seen in systemic JA, because lupus is different. The underlying disease is different. But MAS, Leishmania can give a clinical and laboratory feature that is indistinguishable from AS. So in lupus is can be very difficult to discriminate lupus-related MAS from Leishmania-related MAS. Leishmania can be facilitated by the immune depression that is seen in lupus due to therapies, for instance, or to the disease itself. But since the treatments are completely different, we need to be careful not to confuse, to misdiagnose leishmaniosis, MAS due to leishmaniosis from MAS as MAS due to lupus.
Really do appreciate your response. There's another question also. The decreasing level of platelet or fibrinogen or increasing level of ferritin, I mean, the dynamic changes could helpful for us. Could it be helpful for us to early diagnosis of MAS?
Yeah, this is a very good question, because for sake of time, I skipped the second part of the project, which was discussed and accomplished in the second day of the consensus conference, which was aimed to identify the laboratory parameters whose change over time is most relevant and useful to diagnose MAS early. And these results have been published in the RMD Open a few years ago, but just a summary. So the 3 lab values whose change over time is most useful and relevant to detect MAS timely are ferritin, platelets, and transaminases. So definitely, decreasing platelets and increasing platelet and transaminases, when they occur together in the setting of active systemic JA, should be definitely an alarm sign for the potential occurrence of MAS.
Thank you very much, Professor Ravali, for your interesting, comprehensive responses. Now we are going to have another lecture by Professor Surjit Singh from India with the lecture on Kawasaki disease at Chandigarh, North India, our experiences over 26 years. Professor Singh, we are all ears.
Very good friend of mine. Hello, Surjit.
Hi, Angelo. Thank you.
Dear Professor Surjit, I should thank you for your patience. Thank you very much, sir.
It's a pleasure being here. Thank you very much for the invitation.
The pleasure is ours. Thank you.
Good evening. So I shall be recounting our experience with Kawasaki disease at Chandigarh, which is a city in the northern part of India. I work in the Advanced Pediatric Center here, and I look after the pediatric clinical immunology and rheumatology unit at the center. We diagnosed our first patient with Kawasaki disease in the year 1994. At that time, it appeared that this is an uncommon condition in the Indian setup. But over the last 26 years, it has become very obvious that this disease is rather common and that many patients are being missed all over the country. So as we all know, the condition was first described by a Japanese pediatrician, Dr. Tomisaku Kawasaki, who incidentally passed away this year on the 5th of June at the age of 95. He published his first report of 50 cases of what he called mucocutaneous lymph node syndrome in the Japanese journal Erurgy, which basically means Japanese Journal of Allergy. This was a very comprehensive clinical description running into 44 pages, in which Dr. Kawasaki described all the clinical findings that he had recorded on these patients. Kawasaki disease is a rather common condition, and the three countries with the world's highest incidence of Kawasaki disease are Japan, Korea, and Taiwan, all in the northeastern part of Asia. These three countries not only have the world's highest incidence of Kawasaki disease, but for reasons which are not clear, this incidence is still increasing. So this is the incidence curve of Japan, this is of Korea, and this is of Taiwan. So these curves have still not plateaued down as compared to the rest of the world, where the incidence has plateaued down. Why these three countries still have an increasing incidence of Kawasaki disease is still not clear. We have been documenting the incidence of Kawasaki disease based on our hospital experience at Chandigarh, and we have showed a steady increase in incidence of Kawasaki disease over the last 2.5 decades. We also note that there is a bimodal seasonality with peaks in October and May. Over the years 2009 to 2014, the incidence showed a further increase, and during this time, the mean incidence was somewhere around a little above 5 per 100,000 children below 5. This incidence figure is lower than the reported incidence from the European Union. The median age of diagnosis during this time is much higher than what has been reported from other countries, but this is probably because we have been missing the diagnosis in very small children in whom Kawasaki disease is probably being confused with other viral infections. So this is a false high age of 7.7 years. This may really not be true. As I said, the mean incidence at Chandigarh during this time, 2009 to 14, was around 5.35 per 100,000 children. Over the last 5 years, we have documented a further increase in incidence from 5.64 to something like a little above 10 And now our incidence figures are comparable to the incidence reported from Europe. What are the guidelines for diagnosis of Kawasaki disease? Dr. Tomisaku Kawasaki himself suggested some guidelines based on his original description of 50 patients. And since that time, over the last 53 years, there have been several revisions of these guidelines. But essentially, whatever Dr. Kawasaki described in 1967 still holds true. After Dr. Kawasaki's description, we had the Japanese Ministry of Health guidelines in 1970. But at that time, the coronary artery abnormalities had still not been recognized. And of course, at that time, there was no effective treatment for Kawasaki disease. After that, we had the consensus guidelines in 1989. And then, of course, the American Heart Association guidelines in 2004. In 2017, the American Heart Association gave its revised set of guidelines. And there have been some minor changes in these guidelines as compared to the 2004 guidelines. But essentially, the principal features remain the same, which is erythema and cracking of lips, strawberry tongue, erythema of oral and pharyngeal mucosa, bilateral bulbar conjunctival injection, rash, which can be very variable, but is almost never vesicular. And then erythema and edema of the hands and feet in the acute phase, and the typical periungual desquamation in the subacute phase. Cervical lymphadenopathy, which for some reason, we don't know why, is usually unilateral, and one node more than 1.5 centimeter meets this criteria. So the 2017 guidelines, there were certain changes in the nuances of the criteria, but essentially not much had changed between 2004 and 2017. There is usually no problem in diagnosing the classic cases of Kawasaki disease, and most pediatricians in India now are familiar with diagnosing Kawasaki disease. So this is a 9-month-old boy who had fever for 8 days, extreme irritability, red lips and tongue, and there is usually no problem in diagnosing such a baby. A 5-year-old boy, fever for 6 days, extreme irritability with red lips and tongue. Again, the diagnosis will usually not be missed. However, in infants, diagnosing Kawasaki disease can sometimes be a challenge because the clinical features are more subtle. So in this 10-month-old boy, he had fever, he had increased irritability, which was initially thought to be because of meningitis. He was put on antibiotics, then he developed a rash, and then he developed the typical swelling over dorsum of hands and feet. And it was at this time that the concerned unit thought of Kawasaki disease and treated the patient. This swelling over dorsum of hands and feet is rather specific for Kawasaki disease, and there are very few medical conditions in children where you would get this swelling other than Kawasaki disease. A 5-year-old boy who had fever and cervical lymphadenopathy, and this was initially thought to be because of suppurative lymphadenitis, and he was given antibiotics, but the fever went on, and later the child developed a rash. He developed the red cracked lips. There was high CRP, raised ESR, thrombocytosis, and then the diagnosis of Kawasaki disease was made. Like all conditions, like all diseases, there are several caveats to the diagnosis of Kawasaki disease, and it is these caveats which make the disease so very challenging. Some patients with Kawasaki disease would not meet the diagnostic criteria, and this is known as incomplete Kawasaki disease. And it is believed that almost 1/3 of patients with Kawasaki disease have incomplete forms of the disease, which basically means that the criteria that we have for Kawasaki disease are not specific enough for diagnosis of Kawasaki disease. A 2-year-old boy who had fever for 7 days and rash. There was no clue to the cause of fever. He was given broad spectrum antimicrobials, but the fever persisted. Then the baby developed perianal peeling. Now, this perianal peeling is very specific for Kawasaki disease, and this perianal peeling does not occur in any other known medical disease. But this child did not have the other criteria for Kawasaki disease, so obviously this baby had incomplete Kawasaki disease. This perianal peeling is an important clinical finding because it usually appears much earlier than the pathognomonic periungual peeling, which usually occurs after day 9 or 10. This perianal peeling can be seen in the first few days of fever. So if you have a small baby in whom the fever is persisting and you don't have a reasonable cause for the fever, one must open up the nappy and look for the perianal peeling. So this was a febrile child, again, no cause for the fever, and the baby developed reactivation of the BCG site. No other clinical features. So this again is almost pathognomonic of Kawasaki disease. Reactivation of the BCG site occurs more commonly in infants, and for some reason is more common in countries like Japan and Taiwan. We don't see it very often in India for reasons which are not very clear. In India, all babies get BCG vaccination at birth, but we have not seen too many patients with BCG site reactivation. But if in a febrile child you see such reactivation, then this is virtually pathognomonic of Kawasaki disease. This was a 5-year-old boy who had been running fever for 15 days. He had rash and he had red eyes. Now, this was the clinical picture of this baby. We sought a dermatology consultation, and the differential diagnosis was that could this be Stevens-Johnson syndrome? But the fever was high grade and it was persisting. And in the beginning of this illness, the baby also had red eyes. So we thought that this is more like Kawasaki disease. We gave the child intravenous immunoglobulin, and on follow-up, the baby developed very prominent Bose lines, and then he developed onychomedisis, sloughing off of the nails. So this was indeed an unusual presentation of Kawasaki disease with lip changes that were reminiscent of Stevens-Johnson syndrome. This was a 5-year-old boy who presented with fever for 17 days. Now, whenever children develop prolonged fever in India, infectious diseases are always the first possibility. So he was thought to have enteric fever. He was given treatment for enteric fever, but the fever persisted. And then he developed irritability, but there were no other symptoms and signs. When this baby reached our institute, the treating team thought that the child has received adequate antibiotics. The workup has been negative. So could this be infective endocarditis on a normal valve? So they got an echo done, and echo showed large coronary aneurysms. We subsequently got a dual source coronary angiography done, and this baby by that time had giant coronary aneurysms. But he had only these clinical features. So this child again definitely had incomplete Kawasaki disease, but with disastrous consequences. Some patients with Kawasaki disease have unusual clinical presentations, and this is what is called as atypical Kawasaki disease. So this was a 4-year-old boy who had fever for 25 days, cough and respiratory distress. He was put on ceftriaxone and cloxacillin, but the fever kept on persisting. Cultures were negative. Someone in the rounds noticed periungual desquamation. So the workup was repeated, and there you have thrombocytosis, raised CRP, elevated ESR. The echo was normal. So based on these findings, he was given intravenous immunoglobulin and the fever responded. So pulmonary presentation of Kawasaki disease can be a diagnostic challenge, and this often results in delayed diagnosis because the focus is often on the lungs when it should be on the whole child. Incomplete Kawasaki and atypical Kawasaki disease, these are by no means milder forms of KD, but in fact, the converse may well be true. The reason is that when the baby presents with either incomplete or atypical Kawasaki disease, the diagnosis is likely to be delayed, and therefore you are likely to have more complications. Missing a diagnosis of Kawasaki disease, I need not emphasize, can have disastrous consequences. This was a 17-month girl who had been running fever for 3 weeks. There was excessive irritability, there was a rash. When the treating pediatrician got a urine examination done, they found pyuria. So when the child already had fever, when they had pyuria, they thought this is because of urinary tract infection. So they gave antibiotics for urinary tract infection, but the fever persisted. The child was investigated on lines of a urinary tract infection, but multiple urine cultures were sterile, ultrasound was normal. Since the fever was persisting, a lot of radiological investigations were done, which were normal. And of course, MCU and IVP were also done. Again, they revealed nothing. Later, someone noticed periungual desquamation. So this baby workup at this time showed anemia. The platelets were not too high, but the ESR was very high and CRP was very high. But by this time, the baby already had developed coronary artery aneurysms involving all the coronary arteries. So in this case, the pyuria that this child had was not because of urinary tract infection, but it was the sterile pyuria of Kawasaki disease. And Kawasaki disease is perhaps the commonest cause of sterile pyuria in children. So whenever in a febrile child, you have pus cells in the urine, cultures are sterile, you should think of Kawasaki disease and work up accordingly. And this is the dual source CT coronary angiography films of this patient. This child had developed large aneurysms. Myocarditis can be an integral part of Kawasaki disease. And it is now believed that myocarditis occurs in all children with Kawasaki disease. It is just that we may not be in a position to pick up myocarditis because it's all that you can do to pick up myocarditis is in fact echocardiography, and echocardiography is not a very accurate tool to pick up myocarditis. And children with KD can at times be lurking around in the intensive care unit because of Kawasaki disease shock syndrome. And Kawasaki disease shock syndrome is liable to be mistaken for septic shock syndrome. This was a 5-year boy who had a subacute febrile illness, conjunctival injection, redness of lips, strawberry tongue, and irritability. He had anemia. There was the total white cell counts were high. There was predominant polymorphs. Platelets were initially normal, but then they started climbing, and he had thrombocytosis. The transaminases were elevated, but look at the serum pro-BNP. This was very, very high. 2D echocardiography showed a low ejection fraction, but the coronary showed subtle signs in the form that the Z scores were a little high, the coronaries were bright, the left anterior descending, there was no distal tapering, right coronary artery was bright and ectatic, and there was mild pericardial effusion. These are all soft signs of Kawasaki disease. This child suddenly became very, very unwell, and he went on to develop full-blown macrophage activation syndrome. So the hemoglobin fell from 104 to the 60s and 70s. The total counts fell drastically. Absolute neutrophil count fell. The platelets went very low. Ferritin was very high. Fibrinogen was on the higher side. And so this child had a very hectic stay in the intensive care unit. We gave him 3 doses of intravenous immunoglobulin. We pulsed him with methylprednisolone followed by oral prednisolone. We also gave him infliximab and oral cyclosporin. And he required pressor support, he required ventilation, but ultimately recovered. So this is one of the most serious complications of Kawasaki disease when they present with myocarditis and macrophage activation syndrome, and both of these can sometimes come present together. The child gradually recovered, but fortunately, the coronary arteries did not show many changes. Kawasaki disease is a disease of young children. Most children are below the age of 5. It occurs in preschool children, but it can sometimes present in older children and adults. And that is when it can again be associated with a lot of coronary complications. And such patients are liable to be diagnosed very late because you don't think of Kawasaki disease in adolescents and adults. So we had a 30-year-old female who presented with fever. She had red eyes, a red tongue, a generalized body rash, and she also had a lower motor neuron type facial palsy. So fever persisted for several days. She was given antibiotics. Then she developed a rash. And when she developed a rash, the parents sought a dermatology consultation, and it was a dermatologist who noticed these changes in the palms, who noticed the periungual desquamation, who noticed the strawberry tongue, and he referred the patient to our institute. And this was one instance when in children's ward, we admitted a 30-year-old patient for treatment of Kawasaki disease. So by the time we saw the patient, she already had Bose lines. So whenever Kawasaki disease occurs in adolescents or in adults, the diagnosis is likely to be delayed. And these patients are at increased risk of development of coronary artery abnormalities. Fortunately for this patient, she responded well to intravenous immunoglobulin, but we also gave her infliximab because of the severity of the disease that she had, and she recovered completely. This was another patient. She was 27 years old. She presented with fever, rashes, cervical lymphadenopathy, desquamation, and red lips and tongue. And she had peels of skin coming out of the hands. The echocardiography did show aneurysms, although at this age, it's very difficult to get a proper acoustic window, but she had aneurysms. However, she responded to IVIG, and these aneurysms settled on follow-up. So Kawasaki disease is a common childhood illness. As I said, it is more common in the northeast Asian countries. In Japan, the incidence now is well above 320 per 100,000 children below 5. Approximately 1% of Japanese children develop Kawasaki disease before they reach the age of 10. And incidence in Japan, Korea, and Taiwan is still increasing. Beware of young children with unexplained fever for more than 5 days, and one has to be on the lookout for the clinical findings of Kawasaki disease. It can at times be a diagnostic nightmare because none of these principal clinical findings are pathognomonic of Kawasaki disease, and you have to be smart enough to pick up the temporal sequence of the clinical features of Kawasaki disease. Otherwise, you will miss the diagnosis. Kawasaki disease is rather unforgiving, and missing out on a diagnosis can have disastrous consequences. However, the clinical features of Kawasaki disease are rather vague. The diagnostic criteria are still anything but specific, and therefore diagnosis is more art than science, and this is not what it should be in the 21st century. It remains a riddle wrapped in a mystery inside an enigma. So this is Dr. Kawasaki at the International Kawasaki Disease Symposium in Yokohama in June 2018. Here he is with his 2 daughters. And this is Dr. Kawasaki with some of our residents from Chandigarh at the Yokohama Symposium. We lost Dr. Kawasaki this year on 5th of June. Thank you very much.
Thank you very much, Professor Singh, for your interesting, nice lecture. We really do miss Professor Kawasaki. Let me see if there's any questions. Yes, there's one question, Professor, if you let me to ask you. We need a new criteria for atypical incomplete Kawasaki. It's different from incomplete Kawasaki that is defined by 2 clinical manifestations and some laboratory findings. Some patients do not have any clinical findings except fever. Do you agree with Professor Ziai?
Well, yes, this is a very good question, but I'm afraid I don't have an answer. Because Kawasaki disease, when you say it is incomplete, it is incomplete at a point of time. The child with Kawasaki disease starts with fever, and in the first few days, the child may have some clinical findings. If you miss these clinical findings, fever is persisting, the next pediatrician who sees the child may not see those findings. And by this time, the child may or may not have other findings. So you may think that it is incomplete at that point of time, while in reality, some of those clinical findings may have disappeared later on. There is some confusion whether incomplete and atypical Kawasaki disease refer to the same condition or whether you should treat them as 2 different conditions. We prefer differentiating incomplete from atypical Kawasaki disease. Incomplete is when the criteria are not being met, while atypical is when there are atypical, unusual clinical findings. For instance, involvement of the renal system, involvement of the brain. That is what we would call as atypical Kawasaki disease. Yes, we need to have strict criteria for all types of Kawasaki disease.
Thank you very much for your comprehensive, nice response. If there is anything, other questions? No, we don't have any questions. If I wanted to ask if Dr. Badran is with us or no, please raise the hand. Professor Badran, our next session is with Professor Badran.
I'm afraid she's not with us right now.
As we're unfortunately a bit late for our program.
Who is not with you?
Professor Badran is not online right now. there's a problem.
There's a noise, yes. There's a technical problem. I don't know.
Oh, that's my helicopter flying to pick me up.
Okay. So wrap it up.
Very nice lecture, Dr. Singh.
Thank you. Thank you.
Thank you for your lecture. Because we are a bit later than our program, we are afraid that we are late. And if you are agree, we do not play the pre-recorded presentation of Professor Badran, but it will be available on our YouTube channel. And from each one and every one of us here at Children's Medical Center, Tehran University of Medical Science, we would like to say a particular thanks to Professor Herandish, Professor Fanos, Professor Ravelli, Professor Singh, and also Professor Badran that have prepared a presentation for us, whose support we are honored to have. And despite the time difference, we are more than happy to get involved. And a special thanks to you also, and for our fantastic audiences.
I should also thank all of you, and special thank to dear Professor Khairandish, Professor Fanous, Professor Rabedi, and Professor Singh to share their knowledge, their science with us. Thank you very much, and have a good night.
Thank you.
Thank you
for having us. Thank you very
much.
much.
Thank you.
Bye-bye.
Bye-bye.
Just
stay safe. Thank you.
Yes. Thank you. You're welcome.
Again,
if you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. And don't forget to follow us on our YouTube channel and to be updated about next events. And again, our sessions are available in our YouTube channel, and you can download this. And the presentation of Professor Badran will be available, and you can download this. Thank you very much. Be safe and take care of yourself. Thank you. Good night.
Thank you.
Thank you.